Assalamu alaikum. يعطيكم العافية. Thank you for your attendance. Inshallah, today we'll be starting with the Urodynamic workshop by presenting our lovely friend and our consultant, Dr. Riyad Almossa, who is a consultant in neuro-urology, section head of neuro and urology avoiding dysfunction at urology department at King Faisal Hospital, and he's a CEO on Qatif Hospital. He's a Saudi and European Board of Urology and Urology Fellow from University of Toronto. MashaAllah, he has more than 25 publications, including in the 12th chapter. He has one publication in Campbell as well. So let me welcome him, Dr. Riyad, and inshallah we will be having fun with this session. We already had him last year, and inshallah we'll be continuing having him. And hope you will enjoy the course, inshallah.
Good morning, all. It's a great pleasure, as usual, for me to be here in Kuwait. I was just telling Dr. Talal last Thursday I was here in Kuwait, came back home on Saturday, and came to Kuwait last night. And I have one slide that shows some of the attendees for the workshop last year. Unfortunately, I put it at the last, but I should actually put it here first. Shukran, Dr. Talal, for the introduction. Can we start by just giving quick introduction again from the audience, just to know your name, level of training, and just whether you have any connection with urodynamic, you have some experience. Let's say if we say from scale 0 to 10, what's your level of relation with the urodynamic? Yeah, go ahead. Yeah, correct. correct. إن شاء الله اليوم تطلع على الأقل ليفل 1 or 2 إن شاء الله. ياك الله. يا شريف. Excellent. يا شريف. Excellent. I mean, when I say like experience, means that I've seen the device, I worked with it, I attended some procedures with even some seniors, so it's not like 100% like this is what I'm. Definitely for those who are like experts and they work with the aerodynamic machine every day, probably they won't come and attend the workshop or aerodynamic course unless they are really seeking certificates for that. تفضلي. ممتاز. الله يعطيكم العافية. حيا شاء الله. تفضلي. You're doing urodynamic during your practice. Okay, excellent. Good morning. So you are the expert here in the field. Excellent. How frequent you do urodynamic, like on a monthly basis, average? An average monthly? Excellent, excellent. A good number, good number. Assalamu alaikum. Alaikum. أهلا بك حياك الله. ما شاء الله. في Urodynamic machine and you do cases. Excellent. How frequent you do Urodynamics per month? Excellent, excellent. Welcome all. And I'm really glad to see we have 3 residents in Kuwait board, all urology. We had in Saudi Arabia when we started. I started the program very early, like in late 90s, 98, and we used to have only 1 resident, female resident in the whole kingdom. Now in the Eastern Province, I think we have 10, just in the Eastern Province. So mashallah, they are invading, females are invading urology specialty. طيب, as you know all, this is I think everybody was exposed to and have seen this program. We might have some changes in the timing. And if you see that the program, this is like 30 minutes, this is 1 hour. It depends on the flow, it depends on the discussion. But last year, we had half-day session or half-day workshop. And thanks God, it was good, interactive. So this year, Shabab, they wanted to have it like 1 day, full day. It's more or less the same with little bit of expansion on some of the discussion related to the indications, and probably you will see we'll have more discussions. Morning, I defer the morning sessions only for like most of the preparation, setup, more theoretical. In the afternoon, there will be like more of discussions related to the troubleshootings, interpretation cases, but it will be like more of interactive. And believe me, there are some slides that I did not even prepared, to read exactly. I just put some Urodynamic tracers, and I might discover it with you here. We'll just discuss it. فممكن بعض الشغلات ما أعرفها. I just put some extra. I just wanted to see, depends on the time, whether we will discuss it or not. This is a program. Hopefully, as I said, by the end of this workshop or course, you will have an introduction. We always say, المرء عدو ما يجهل. Urodynamic used to be during our training, during our residency. Probably this is the last, as a urology resident, last thing I want to touch. I feel it's anything related to neurology, it's tough, it's difficult. So I don't want to go, I don't want to intervene. Let me just go do some endoscopies. And this is just an introduction for everybody to tell them that urodynamic, we're not saying it's easy, but is not really complex the way everybody thinks. It's something that if you practice it, it's a very useful tool, and it will be helpful for your patient and yourself to practice it during your training and during your work as a urologist or gynecologist or whoever specialty practicing or connected to urodynamic. This is where my hospital, or let's say my urology work, I have administrative roles, but in King Fahd, it's King Fahd Specialist Hospital, not King Faisal. We have established the neurourology voiding dysfunction unit 15 years ago, 2008. We run an average of 450 to 500 urodynamic a year, 3 to 4 sessions. Usually it's done by our a specialist with a support of resident, and we have nurse practitioners who are certified in urodynamic, but they're not doing the urodynamic themselves, but they are just supporting the team. So we just put the that the physician has to do the urodynamic. And do you have any problem here? I think do I need to touch it every time or? لا واضح الكهرباء اليوم ما طيب. Again, we're proud, alhamdulillah, and we last year our neurourology fellowship program was accredited by the Saudi Commission, which is the first in Saudi Arabia, and as far as I know, it's the first in the Gulf region as a full fellowship program that's based on the Canadian fellowship, which is similar, I would say. It's an improved version of the fellowship that I had in Toronto, Canada. So in January, we're starting our first candidate joining us. We had 14 applicants, but every year we'll have one fellow. Alhamdulillah, it was one of our dreams that came live and true, and hopefully this also will add to the introduction of the specialty that we are discussing. Any problem?
Yeah, it's off. Hang on.
طيب, I'll try to be interactive as much as possible, يعني with the respect of the time. But anyone can tell me, when do you think the urodynamic was approved as one of the modalities of investigations in urology? متى بدينا نسمع بحاجة اسمها urodynamic؟ مو احنا طبعا، قبل يعني متى في in your readings you have seen that urodynamic was there. When do you think? It's not like, even if not an info, 10 years. أنا أقول من 2008 أنا بدينا اليونت وشغالين فيها قبل فلسفة، لا يعني خليك كريمة شوي. 60s? Excellent, good guess. Urodynamic concept لما نتكلم على what is it? Urodynamic basically, and I will put this in the slides here, we're talking about assessment of the function of lower urinary tract. We're talking about two key tools that we will measure, which is the volume and pressure. With the volume and the pressure, this is how all the urodynamic data come. The concept started in the early 1800s, يعني في بداية 1800 started the concept without the term urodynamic. It's just the concept, how can we measure intra-abdominal pressure, how can we measure the bladder pressure in order to correlate it with the function. So the concept was there, but they don't have the tool. They don't know how to do it. So they started, unfortunately I have some pictures here. They started by putting some funnels with some wirings, trying to put a wire connected and measure. It's like mechanical, يعني just to see how can I measure and see. When we talk about the initial, probably when they present here, they will say multi-channel urodynamic. started with, طبعا, there was nothing called multi-channel. Multi-channels means we have different channels to measure different pressure, different parameters. When it started, it was a single channel. It was a wire, or let's say a catheter, that measure the pressure inside the bladder. But it's not the pressure of the uteroser, it's the pressure of the vesicle, which includes the pressure of the abdominal. So it was just like, simple to give them a hint to see what's going on. Or it's like a small catheters, putting some funnel and leveling it with the patient. There was no machines running. And it used to be like, طبعا ولله الحمد ما لحقنا عليها, it used to be like a manual calculation. And now everything you get from the system with just a button, and you get all the formulas. I will show you some formulas. I will tell you, don't memorize them unless you are going for an exam, because we don't need to memorize them now. It's all in the system. You just get the numbers. Luckily, you'll get all the data that you need. But the word urodynamic came at 1954. 1954, that was the born of the word urodynamic in the history of urology. في urologist, scientist called David Melvin Davis from Philadelphia. He published a paper in Annals of Surgery in 1954, and the title of that was The Hydrodynamics of the Urinary Tract, between brackets, Urodynamic. That was the first time in literature you see the word urodynamic. 62 started with other scientists. We started to see, do you need to put it in another computer, or is there a problem with the computer or with the screen? I think it's not, no, you just need to connect it's there, but here, just, it's jammed here, I think. أنا ما أبغى ألمس شيء بعد لا يضرب شيء جديد. Anyhow, in the early 60s, 1960s, start to see like more and more advancement in the work of, طبعا, by the way, the advancement or revolution that happened in the urodynamic, it was not only for the urodynamic device. We're talking about, I'm a functional urologist, I'm a neurourologist. The neurourology field in urology has its greatest revolution over the last 60 years. So when we talk about late 60s, beginning of 1980s, that was the real revolution of all the advancement in the field of functional urology. Just put the slideshow. No. Hopefully this time it works. This is my disclosures. I have nothing to disclose, but it's not related to this course. This is an example. I was told that the pointer will not show on the screen, but this is an example on the right-hand side of the basic urodynamic. Down, it's similar to what you see here. It's what we call the advanced urodynamic or multi-channel urodynamic. This is the gentleman. If you look at his face, you think he's like President of United States. ما شاء الله كانوا كشخة دائما. Mr. David Davis, and as I said, في 60s Davis again and Zemskind. I said it's an annal of surgery they started. In 1962, it was the first time they published in a urology journal of urology, the one that everybody knows in urology, اللي هي الجورنال الأمريكية. Sosset, what's relation of history of urodynamic to Sosset? I would say Sosset, in my opinion, was the best who described exactly what is the definition of urodynamic. Sosset wrote in 1985, the medical science concerned with the physiology and pathophysiology of urine transport from the kidney to the bladder, as well as storage and evacuation of urine. This is the definition of the whole functional urology. And in order to assist this with an objective measuring tools, you need to have a urodynamic. Till now, this is the definition that is, I would say, even the international societies has approved it with some a little modification. The goals of the urodynamic, it will reduce the patient's symptomatic complaint. يعني الpatient, and I will do this test to make sure I'll try to reproduce symptoms that you are facing outside, and I'll do it. موجود في الغرفة بيطفي يا شيخ فل هو على العموم I have flash but I think it's full يعني it usually takes 8 hours anyhow and it provides a pathophysiological explanation by correlating symptoms with the findings. For sometimes you have symptoms you don't know whether it's really coming from the bladder or not. There is pain. I don't know, is it related to the filling of the bladder or not? And incontinence, is it related to the bladder or it's something different pathology? I need to investigate this. So you have to correlate the findings with the symptoms, so you need to have a tool, which is the urodynamic. Again, reproducing the symptoms that everybody is facing when they come and say having incontinence. It's not continuous. It's like once, if I have full bladder or if there is an issue, if I have cough, or if there is an increased pressure, or sometimes if there is a provoking factors. So I try to reproduce these symptoms by doing this test and hopefully getting what I could get during the daily life. When we go into the details of the types of urodynamic, we'll say what's the advantage of having an ambulatory urodynamic or the conventional urodynamic. As I said, the key words, the key factors are the volume and the pressure. Urodynamic, basically, أسهل حاجة. It just measure volume and the pressure. A lot of formulas comes in, and we'll just give you all the details about the function. It's not magic. They will measure volume and the pressure. The basic urodynamic, there is, everybody knows Euroflow, صح? Euroflowmetry. Euroflowmetry is the simplest urodynamic test. It's again a part of the urodynamic, but it does not have, what's the limb that's missing? Pressure. It talks about volume and velocity. But it does not have pressure. If once we add the pressure, we'll get the full urodynamic assessment. This is by the International Continence Society. Look at the definition. As the study of the function and dysfunction of the urinary tract. They summarize it. Isn't it the same as the definition that was said by Sosset? The same. He mentioned pathophysiology and physiology, function and dysfunction. And they said storage and evacuation of the urine, the detailed one. They summarize it as study of function and dysfunction of the urinary tract. Just to tell you how prevalent is the lot symptoms. We're not talking about something that's one patient in 100,000. We're talking about a very prevalent disease. If we take an overactive bladder only, overactive bladder, 1 in 6 people will have symptoms related to overactive worldwide. These are the storage and voiding symptoms, and just to remind ourselves, and post-micturition, which is the entity of the lower tract symptoms. When you say lower tract symptoms, Either they have storage, which is urgency or incontinence, increased daytime frequency, nocturia, or pain, or they have voiding. Storage, if you remember, there is an alternative. It's either storage or what? It is a storage and evacuation, but these symptoms, either we call it storage, irritative symptoms. This is related to irritative symptoms. This is voiding or obstructive symptoms. For either voiding or there is an obstructive symptoms. So we'll see slow stream, splitting, intermittency, hesitancy, straining, or terminal dribbling. Post-micturition dribbling, feeling of incomplete emptying. It's what we call it post-micturition. It's not related to obstruction, but this is post-micturition symptoms. These are the lower tract symptoms that we basically assess. Lots, 66%, 67% of people will have once in their lifetime at least symptoms related to lower tract symptoms. We'll have storage symptoms, which is almost 60%, voiding almost 25%, this is male and female of course, and post-micturiation almost 15%. Among all these symptoms, nocturia is the highest. نتكلم على almost 50% of the symptoms are related to nocturia. We're talking about bothersome symptoms. Yani if we go to the patient, tell them, what is your most bothersome symptom? He'll tell you the nocturia. Maybe they have frequency, maybe they have urgency, but nocturia is the one that's bothering them the most because they just need to wake up, it's disturbed their sleep, it will affect their morning work and daily activity, so they will be bothered more, and it's not a surprise for us. As I said, 1 in 6 adult has overactive bladder. In America itself, only 37 million complain of overactive bladder. We're talking about more than 200 billion cost and the budget just related to lower tract symptoms. It's higher than bronchial asthma. It's higher than diabetes, believe it or not. And we're talking about one diagnosis. When we talk about neurological disease, which is not an overactive bladder, we're talking about a neurological lower tract symptoms. We're talking about almost 100% of those patients with a neurological disease, and you know how much vast and big neurological disease classification, they have urgency or voiding the symptoms. Obstructive symptoms constitute almost up to 80% of those patients will have some sort of obstructive symptoms. Chronic urinary retentions, quarter of those patients will have chronic urinary retention. Irritative and obstructive symptoms, it's almost 60% in men, 50% in female. So voiding dysfunction increase with a neurological disease duration. طبعا كل ما زاد السنوات, the more patient has as a neurological disease, they will have more symptoms. And neurological disability. And this is one of the classification when they classify patients with Parkinson's or neurological disability. I just brought those two diagnoses. I did not speak about prostate. I did not speak about stress urinary incontinence. I did not speak about other indications, just to show how much load you have in your clinic as a urologist or a female urologist or urogynecologist of those patients who will suffer from lots that you might need. You mentioned you're doing almost 10 cases a week, 3 or 4 cases. I mentioned almost again another 50 cases a month. This is just a fraction of 1% of all those cases who might need urodynamic. So it's a really big population. Your population, your targeted population is huge. And in spite of all the delay, alhamdulillah, we managed to finish. Now, what about the applied anatomy and micturition physiology? طبعا we have 2 ways to do it. Either bring you the very complicated pattern of micturition cycle and the physiology and just make your day really hard. You will go out from this course saying, you know what, as usual, we know that the micturition process, it's very complicated. We cannot understand it. There are some themes that you need to understand it for the exams. But as I said here, we need to simplify it. Look at the presentations or the slide as like a take-home messages, each slide. So we're just trying to discuss and see what are the real things that needs to stick into your mind. We're not here to discuss Campbell book or goes into the details of each one. لأنه, as I said, data are there in the books, but we'll try to pick those data which needs to stick in your mind that might help you in your practice. This is like more of a practical course. Probably this is the simplest diagram I could show you. And I just want to show you one thing here related to the micturition process and the physiology and anatomy of the micturition process. It's really complicated, the micturition process. We're talking about lower tract, which involves bladder, represented في الكمة هذه by the detrusor muscle, and we have the pelvic floor that has fast and slow twitch fibers. This is the second member of the committee, and the third member of the committee, which is the external sphincter that has slow twitching fibers. These are the components. طبعا في details, prostate, urethra, we're talking about these are the components of the lower tract that the micturition process are heavily involved on those three members. طيب, who controls the process of micturition? Who controls the process of storage? It's not only one body. It's from up till down. من الbrain itself, يعني المaster of the human body controls the micturition process في أعلى نقطة, cerebral cortex. And again, in order to show you how much it's important the micturition is, they created a pontine in the pontine area. By the way, although we have a lot of brain injuries, things that are affecting the voiding symptoms, if you look at the pontine, ترى it's among the most part in the brain that's protected. يعني it's not in a peripheral area, في مكان central. So unfortunately, if any accident hits that area, it will affect the voiding heavily, but it is a very protected area. God made the control in this area because it's known that this is really crucial to the quality of life for that patient. So higher centers at the pontine and the cerebral, down up to the spine, goes through the sacral, where the lower, when we say upper motor neuron region, lower motor neuron region, we are talking lower to the sacral. Who knows which sacral root that is responsible with voiding? S3. S3 is S3 is the magic number for the controlling of voiding. فنتكلم على sacral nerve root 3. طبعا 2, 4 they have. We're talking about 3 as the main one. The connection basically تجي signals from up here. If there is a stretching of the bladder, sensory input from the stretching detrusor muscle will goes to the sacrospinal cord, goes back through the parasympathetic pelvic nerves. Parasympathetic pelvic nerve. Who's Egyptian here? المصريين علمونا في التدريس يربطون بكلمة كذا وعشان تحفظها. أنا أذكر لازلت رغم اللي درسته كله، أذكر الدكتور اللي علمنا في البداية ربط الباراسمباثيك والبلفيك قال بي بول، ربط حتى البول فيها فقال this is where the micturition is. طبعا هو كان Egyptian. فباي ذا واي the moment we looked at it إيش بعدين تقرأ 100 كتاب لا زالت راكزة في دماغي هذه. فباراسمباثيك نيرف البلفيك نيرفز responsible about putting micturition contraction عشان المريض يتبول. Pudendal nerve, it's somatic. It's more at the motor here, and this is the area where it is the one responsible about relaxing and contracting the pelvic floor and external sphincter. If the patients will void, the external sphincter and pelvic floor will relax. If the patient will fill the bladder, it will be contracting. This is the normal physiology. طيب, what happens if there is an abnormality? لما نتكلم على suprapontine and pontine lesion مثل ما قلنا higher up, هذا examples of diseases that we have. يعني CVA, dementia, neurodegenerative disease like Parkinson's disease, brain tumors, a trauma at that area. طبعا, what is the importance of this level? When we talk about levels, what's the importance? Why we need to differentiate? If it is higher, if it is a lesion at the area between the sacral spine root and the suprasacral, or if it is the sacral area, or if it is peripheral. What? Excellent, which means? Excellent. The level is responsible about how the bladder will present to you. When you know the level of the injury, you would propose or expect what exactly the bladder will behave. طبعا, we are talking about some variations. There are some variations. There is some overlap. Yani you'll have probably, if I will show you on a slide, you might have more percentage of overactive there, less detrusor sphincter dyssynergia, more underactive, and this is the way it connects. There is a chapter that we wrote 8 years ago about the pathophysiology of spinal cord injury, and probably just go and Google it. And this is from it. It's part of it related. We took it from the European journal, and it's simple. It will just explain to you what is the level and what are the findings by urodynamic. If there are lesions between caudal brainstem and sacral spinal cord, like spinal cord injury, trauma, again, or spina bifida patient, the findings will be different. If there are lesions related to peripheral nervous disease, like diabetes mellitus, or lumbar spine, or degenerative diseases, again, the findings are different. Or if there are disseminated central disease like MS. MS can affect brain, can affect the spinal cord, and you can have the combination of all symptoms. European Association of Urology, Masterclass classification system. We're talking about the effect of the neurological disability or neurological lesions on the voiding function. صح? When we talk about voiding function, we're talking about, we mentioned earlier, الممبرز حقين الكوميتي. We're talking about في urinary tract symptoms, we're talking about bladder represented by the member which is the detrusor muscle, and we're talking about the urethral sphincter. طيب. Marschbacher, he's almost 90 years old now. He's from Austria, but he is pioneer in the field of neurourology. MashaAllah, la zal active. But this is one of his publications, and this classification system, I think it was published almost 35 years ago. La zal valid and one of the best. So they made the combination of if the lesions are located somewhere, what will happen to the detrusor muscle and what will happen to the urethral sphincter. الدائرة الكبيرة اللي تشوفونها هذه ايش؟ bladder. الدائرة الصغيرة هذه شنو؟ sphincter. It will not go out from those diagnoses. شوفوا الثمانية هذه فيها كل الكومبينيشنز الممكنة لك في الدنيا. يعني مسألة حسابية تحسب لك إياها تطلع لك. You get it. If there is a lesion at the spinal, most probably you will get an overactive bladder and you will get an overactive urethral sphincter. بسرعة هالشغلة شو تسوي؟ Thank you. لما يكون عندك اثنين شغالين واكتف معناها you have detrusor sphincter dyssynergia. لأن هذا pressing وهذا pressing. Both are working at the same time. And instead of the normal physiology, one should be contracting, one should be relaxing, and the other way around. They are both contracting. ففي الspinal, okay, DSD, they will get a DSD. Again, لما يكون lumbosacral overactive, underactive. Most of the time patient will have incontinence لأن it's underactive. السفنكتر ما قاعد يشتغل. There is a lot of contraction, you'll have incontinence. Suprapontine, فوق في العلالي. Patient will have an overactive detrusor muscles. It does not affect their sphincter. It will be normal. They will have an urgency, they will have an incontinence, but there should be no detrusor sphincter dyssynergia because the sphincter is functioning. Lumbosacral, again. Underactive, overactive. Why we're saying that? As I said, when the findings هنا, if there is an underactive for the lumbosacral area, it will be an overactive in the sphincter. Again, as I said, we're talking about highest probability, and if these findings are there, we'll have the findings of the second member, which is the urethral sphincter here. When we talk about if the lesions are at the subsacral, we'll have a detrusor underactive, and we'll have an underactive sphincter. You might have incontinence, you might have retention, but both are underactive. And among underactive, we'll get what we call contractile, completely a contractile. Lumbosacral, underactive, normoactive. Sphincter only, if there is only sphincter injury, bladder راح تكون normal. You will have an overactive bladder, overactive sphincter injury. Or you might have an underactive sphincter. بمعنى يا السفنكتر itself وهذه تكون مع things related to spinal يا sphincter itself يكون overactive ويسبب detrusor sphincter dyssynergia لأنه منقبض all the time, it's always closing, or it's underactive and it causes incontinence. And here where the neuromodulation works and comes, if there are some lesions like this. So these are the combined classification that will not go outside of that box. These are some examples of the urodynamic findings of the conditions that we spoke about. MS احنا قلنا هذه قلنا من demyelinating disease. Usually capacity is not much affected بمعنى size of the bladder. The compliance is acceptable. We'll have detrusor overactivity, and the sphincter function either it's normal or there is detrusor sphincter dyssynergia. لأنه زي ما قلنا depending on the lesion. But these are the usual finding for the multiple sclerosis patient. When you talk about Parkinson's, they might have normal or slightly limited capacity. They might have normal or slightly limited compliance. I will not talk details here about the compliance. When we come out with the compliance, we'll talk about what's the formula of the compliance. They might have earlier, at the beginning of the Parkinson's disease, they might have an overactive bladder تكون more active. At the end of the disease, يكون patients develop an underactive bladder. And sphincter functions is slightly limited in the underactive form. Dementia, more or less this normal, except some limitation related to the compliance and the sphincter function. Diabetes, they might have normal, depends on the diabetes condition control, or they might have more problems related to the capacity that will increase the capacity لأنها بيكون sensation is affected أو بيكون عندهم late compliance impaired because of the increased compliance because of the decreased sensation. الcompliance يعني بدل ما يصير compliance is related للاlasticity elasticity of the bladder, مرونة المثانة. فلما يكون يا أن المثانة مرونتها the elasticity of the bladder is very stretched, تكون it's very active, it will reduce the compliance, so it will be impaired, or it will be like in diabetic patient, they will have the impaired sensation, which means the bladder will be having a huge volume, and this will have a compliance that is positive, which means it's high, negative. It's not impaired, it's high compliance, but again, which is not good, because of the sensation, it will have a huge bladder, and due to the compliance, that is one of the factors that might trigger the patients to void. It's impaired. Peripheral neuropathy, more or less, will be normal with some elements of positive or increased compliance and capacity, with some element of decreased activity of the detrusor muscle and decreased activity of the sphincter. CVA patients, again, they might have normal findings. And these are, by the way, these are from the studies. These are from the studies. There are findings of what are the collective findings of all those patients with the diagnosis. And percentage, when we say 25, 62, 64, 72%, I mentioned to you in one of the slides the neurological diseases where the percentage goes more on those patients. Actually, يكون عندهم more of detrusor overactivity, more of detrusor underactivity. But you will have in the higher list, when you put it in your mind, at least as a reference, you know, by default, if I come here, if there is an MS patient, I will look at the compliance. I will see, is it really impaired? Is it in the negative? I'll look at the detrusor. I'll look first at the detrusor activity. Is there a detrusor overactivity? Because an MS patient, most likely they will have a detrusor overactivity. So when you put it in your mind, you know these are the major findings, but does not exclude other findings. And that's why if we don't have the, let's say, overlap, why do we need to do urodynamic? No need, صح? If we know exactly وصفة موجودة, MS patient, they all will have detrusor overactivity. Spina bifida, they will have a detrusor overactivity. Why do I need to do a urodynamic? خلاص, once I diagnose is there, I don't need to look at anything. But because there are variation, and that's why we need to understand fully the function of the lower tract symptoms, that's why we need to do the urodynamic. But this is a hint. This is a tool for us to help us make sure that is it among the common findings and signs, or is it among the exceptions? The treatment will be different accordingly. شوفوا هذا السلايد, I don't know how many times did I put it in this presentation, طبعا for the whole day. If you need to go out from this room with only one slide or only one data or information, take this with you. Anybody come up with a different diagnosis from what is there on the screen, please let me know. We will get نعطيكم جائزة اليوم نغديكم. This is a collection of all the possible urodynamic diagnoses that you might get. And by the way, الكلام يعني whatever I mentioned earlier, it's little bit repeated but in a different way. يعني احنا لما نقول ان this is the diagnosis of neurological diseases, this is the diagnosis of any lesions related to the spinal cord. Now we're talking about not a neurological, anything related to lower tract symptoms. If I do a urodynamic, again نرجع لي أصحاب السمو الأعضاء اللي موجودين في اللجنة, البلادر واليوريثرا. Let me come and investigate and see how are you functioning when I did a urodynamic. عندنا filling, عندنا voiding, صح؟ This is the cycle حقت الvoiding. I'm assessing, we will mention this during the procedures. I'm assessing the filling phase and I'm assessing the voiding phase. في الفيلينج phase بطلع شغلات وفي الvoiding phase بطلع شغلات ثانية وبشوف الdiagnosis. During the filling, assessing both bladder and urethra. Either the bladder is normal or overactive. سؤال. I need somebody to answer it. Can I check the underactivity here? لأنه ممكن تصير البلدر underactive صح؟ ليش ما حطيت underactive؟ Thank you so much. You never assess the underactivity in the filling phase. هي البلدر المفروض تصير by default. When we say normal and stable, this means what? It's underactive. It's normal. It's a contractile. This is the way the bladder should act. Either the bladder functioned differently, this means it is a detrusor overactivity. So you don't assess detrusor underactivity during the filling phase. طيب, what about the urethra? Again, your first diagnosis should be what? In any of those statements. أول diagnosis يكون شنو؟ الديفولت اللي أنت تحطه بعدين تغيره. The one that you put it, then you change it. Normal status. It should be normal. And then you assess. يعني you're expecting when you put, because guys, here we're talking about doing the procedure, thinking, interpreting the results, writing a report later on, putting the diagnosis, working on the treatment, following a plan. This means I have to put in my mind those diagnoses. فأول حاجة, always put in your mind, I'm doing a study, this is normal. And whatever comes up, this is a deviation. Like, I should understand first what is normal. If you don't understand what is normal, you will not understand that this is an abnormal. So you have to understand that this is normal. فالnormal في البلادر, it should be stable. There is no contraction. فهمتها. طيب, إيش الشيء الثاني اللي ممكن? What might be different? There is an abnormality, which means during the filling, we will have detrusor overactivity. خلصنا؟ في شيء ثاني؟ ما في. طبعا بنتكلم على إيش الفايندنجز اللي بنسويها في الفيلينج. أنا قاعد أتكلم الآن السمري زي ما قلت لكم. This is the summary. This is that if you have thousands of urodynamic machines, if you did your study here or outside anywhere, this will not change. Urethra, يا يكون normal, which means competent, closed during the filling. لأن this is what we need during the filling. The urethra should be closed. Or urodynamic stress incontinence, which means incompetent. يعني خلال الفيلينج مع أي زيادة في البريشر it will leak. Cough, movement, shouting, crying, laughing, any increase in the intra-abdominal pressure, it will leak, which means it's not normal, and it should be competent. When I shout now, I should be competent, not losing my urine because of the urethra, even if the bladder had an increased pressure during this activity. طيب, خلصنا الفيلينج. What about the voiding? Voiding, again, let's come back to those members. Bladder. During voiding, ايش المفروض البلادر تسويه during voiding? Contraction. Normal contractility. ما تيجي تقولي there is a detrusor overactivity or there is a detrusor contractility. This is normal. مثل ما قلنا نقول إن البلادر تكون underactive أو تكون stable خلال الفيلينج. Here we're talking about a normal detrusor contractility during voiding. This is the function of the bladder. Or underactive. Here we see the underactive. When we say underactive, يا جماعة, we're talking about a contractile or any element of underactivity. يعني either it's zero or there is some element of underactivity to the which is not normal or not enough for patients to exercise the normal voiding. Urethra, again احنا كنا نقول هناك competent مقفل. النورمال هنا شنو؟ لو تلاحظون حطينا هنا النورمال فوق، قلنا لازم اعرف النورمال الاول. عندي هذا، وطبعا وتسوي كومبينيشن على اساسها. يعني ممكن يكون عندي disorders of activity diagnosis ويكون عندي underactivity. يعني when you see this diagnosis, don't laugh on my diagnosis. How is this stupid urologist? He's writing disorders of activity and disorders of underactivity at the same time. Yes, because it's an indefinite entity. This is in filling, this is in voiding. And we have many patients who develop disorders of activity and disorders of underactivity during voiding. They have those elements. Disorders of activity is abnormal. Disorders of underactivity is abnormal. Urethra, either it's unobstructed, فتكون خلاص during voiding it's open, or يكون obstructed. طبعا when you go into the details, urethral stricture, prostate, whatever we're talking about, as I said, this is a sum lump diagnosis. لما أقول لكم إنه get me a diagnosis outside this box, we're not talking about the pathological diagnosis. We're talking about what? Urodynamic diagnosis. At the end of the sheet, when you write a diagnosis, you will write a urodynamic diagnosis this way. Normal bladder filling, disorders of overactivity, normal voiding contractility, disorders underactivity, or we say competent urethra or incompetent urethra or obstructed. Later on at the impression, you write down, this is most likely bladder outlet obstruction due to prostate enlargement, لأن أنا connected the dot. You remember when we said urodynamic, in order either to reproduce the symptoms or connect the symptoms and signs together. You will tell in your impression, this will not get you, or it's not an ultrasound to tell you that this is an enlarged prostate, but you have history that this is an enlarged prostate. This patient has a prostate of 100 grams. When I checked the urodynamic, it's obstructed. Obstructed, most likely due to enlarged prostate. So please make sure that this is your take-home slide. And again, don't laugh at me when you see me presenting this in every session during my presentation. Probably you will see it, I can't recall now, in the writing the report, in the interpretation. Whenever there is a slide, I'll just put this because this is really an important. I'm bringing it to you every time, not to explain it, just to stress on the importance of that.
And I forgot to mention one thing, so you don't quote me on it when they come to me here and say, and I try my best, whenever there is an area to mention, I mention it to you. In my slides, not all the data there are 100% just book or guideline slides. Yeah. This is a combination of theoretical and practical. We've been doing it for almost 20 years. We have seen and did for many, many patients. We're talking about almost more than 4,000 or 5,000 patients. So we managed to create our own, let's say, guidelines. I cannot go to my guidelines and say, no, I'll do it. But definitely, it's not like the international guidelines going there and we're going this way. And we're talking about guidelines sometimes is, guidelines are either related to experts' opinion or sometimes related to the study. Sometimes the studies are not there. But by the way, sometimes companies come through with those guidelines by saying, insurance company, you see, this is no indication to you. So you have to do it this way. You have to do it this way. For guidelines, يكون strict to writing it when you go to this is the guideline. There is no indication to be Urodynamic, for example, in that case. طيب ليش انت تسوي له كل حاجه؟ No, I see that this patient is in all cases. طيب الجايدلاينز okay مع احترام and this is the practice that is. So probably you'll see in some slides. If you read something that is different. This means that the code that I got, it's my practice. This is the way I practice it, and this is the way. And by the way, in even international meetings, they're always different. Yani, big example, to do a aerodynamic for patients with a stress surgery, for sleep surgery. I've been fighting about this for almost 10 years. And no, I have to do it for all patients. I have the tool, I have to do it. Is it really an indication related to guidelines? And because we're talking about indications. No, it's not. None of the guidelines will tell you that it is an absolute indication to go and do aerodynamic. بعد 10 سنوات in 2022 last year we start to see the literature more and more supportive of you have to do before surgery for each patient. في article I liked it a lot. Urodynamic before stress incontinence, is it a myth or we're back to reality? And I wanted to put it like in my office, just like one of my certificates. But every year things will change. And every year we'll find a new recommendation saying that, we have, the way I followed, especially the indications for urodynamic, and the way I watched the indications for urodynamic. It started 40, 50 years ago with a few indications. Nowadays, we see more and more strong indications. And if people are not 100% convinced, what they will issue, they will just say, okay, it's not an absolute indication, but it's highly recommended to do so. يعني هم يقولوا نسوي بس مستحيل. We cannot say 100% do it, but if you have the machine, we highly recommend it. And one of my very good friends in Bristol Institute, Dr. Hashim, we were discussing one day, and we were in a debate in one of the international meetings about to do or not to do before the change. So he was the anti, against, I was pro. And دائما مع اليوروبيانيك. So when we finished the debate, طبعا يكون في تصويت. But I know the one who will defend it, they will go with the guidelines. They will say, this is the European guidelines, this is the American guidelines, it does not. So we finished, I put my debate, I put my battles in, and I discussed it with them. But just before the end, and before we asked people to vote, who won it? So I asked Dr. Hashim, and I still remember this, I asked him this question. Before we close up the session. Now, put the discussion aside, and I know that Bristol Institute is one of the biggest centers worldwide in the functional neurology. Do you, Prof. Hashim, in your daily, day-to-day practice, do urodynamic before patients undergoing prostate surgery or not? Yes or no? So he said, yes, we do. But I thought that's it. We're done. Probably that was the only word that I won the vote. And again, it's not, and why I mentioned this, we're not just discussing theoretical, we're talking about our practice. We're talking about day-to-day. We're talking about how can I deal with my patient, not only sitting into the exam, answering this. Okay, good. Go to the exam, MCQ questions. If they say what's the indication, go to 1, 2, 3. But this is different, and the practice is different. And by the way, especially for you as a resident, this is what differentiates between a good physician or a surgeon and someone who you might find an excellent physician. And do stuff. تحفظ books completely, and she or he can spell everything from A to Z. When it comes to dealing with the patient, I have to do it It's not paper, it's not like books, it's not table. You have to tailor it according to your patient's need. But this is important to try to involve your experience, involve your reading, involve your theory, your guidelines, but how to implement it into your practice. We will, feel free to go and grab anything you want, even during the session. For those who are really interested to read more and know more about functional urology and urology in general, this is you know that the holy book is covered. But for incontinence and functional urology, this guidelines or reference is our holy book. The incontinence that is published by the International Incontinence Society. It used to be by International Consultation of Incontinence, now incorporated into the International Incontinence Society, and they publish this every 4 years. The 7th edition was in this year, 2023. And by the way, I think the book is 70. طبعا كلها الان electronic. Nobody reads the hard copy. If you register in the International Incontinence Society, so it's not working. If you register in the International Incontinence Society or in the Pan-Arab Incontinence Society, and unfortunately I did not put the link in my presentation, but you might get a 50% discount for all those members for any books you purchase from that. And this is highly recommended. I know that most of you or all of you here are resident doctora senior, but if you are into the field of functional urology, this is highly recommended. This is just an example of the guidelines. You'll have a lot of algorithms in this book about the guidelines. Incontinence in men, in women, in pediatric age group, in urogenic, fragile, elderly, pediatric, all. There is an algorithm for all, even for painful bladder syndrome. This is just an example, just to show you the regular assessment that includes history and physical examination, the routine analysis, the labs, and treat accordingly. When does this guideline or recommendations, which is usually working group, يكونوا هذا مجموعات, recommend to do urodynamic? This is what we call it initial management. If you see here, any patient with any LUT symptoms, you don't need to do urodynamic. And when we say urodynamic, we're talking about invasive, and we'll talk about the types. As you remember, I told you Euroflow is part of the urodynamic tools. Euroflow is not the one that we say it's not recommended to do. No, we're talking about the invasive urodynamic. If the treatment modalities that were offered failed, we'll go to the specialized management. We'll go into the other page. Or if there is what we call it a complicated incontinence. Complicated incontinence. Yeah, recurrent or total incontinence. It's not stress or urge, it's called total all the time. This is called complicated. Or if there is incontinence that is associated with hematuria, pain, or if there is history of radiation or radical pelvic surgery. This put the incontinence under the category of complicated. فهذا يودي على طول على السبيشاليزed management. ما يدخل, does not go through this dilemma. This is the specialized management of incontinence. Again, if it did not work,
Again, depending on the diagnosis and the assessment that the specialist will seek, they mentioned here to consider cystoscopy if indicated, and consider urodynamic and imaging of the urinary tract. This means if all initial therapy failed for any patient with lots of symptoms or incontinence, specifically here in the algorithm, as I said, this is an example. All the algorithms for male and female, pediatric, neurogenic, speak the same language. But I'll not bring all the algorithm. I'll show you one for the neurogenic, which is little bit different, but they are all the same. When we talk about once we go into the specialized management, which means, basically, what do you mean by specialized management? Why I say in our practice, why I do urodynamic for a patient? This means I have a family physician or a general practitioner or a urologist who is not familiar with urodynamic. He has the right to go and give the treatment and offer the treatment that they think according to what they have as initial, including conservative therapy or medical or limited surgical therapy. And this is not the thing that I agree with, as I said, in my practice, because some surgical options are there. But for me, I don't do any surgery before doing urodynamic. But if failed by the general practitioner or the general urologist or general gynecologist, once he referred this patient to me, I will consider this as a specialized management. For this will put all my patients under the category, I would say most of them, that they will need a urodynamic study. Again, if it is complicated, as I said, we will consider urodynamic, or if there is a failure of initial therapy. And again, all types of treatment modalities are there once you do urodynamic, depending on the diagnosis that you have. And by the way, I'm not sure, but I think algorithms of the books, even if you don't buy it, are available online. And in last slide today, in my all presentations, you will have my email and my Twitter account, and probably if anybody wants to share with me, my number with him or her, you can ask any slides, any guidelines copies. I'll be more than happy to provide you with. Neurogenic, why I mentioned, I'll just bring this additionally to show you that this is a little bit different. You remember in the initial assessment phase for incontinence, urodynamic was not there, صح? It was only in the specialized management, or if it is complicated incontinence. Invasive urodynamic study in selected patients population, spinal cord injury, myelomeningocele, is considered among the clinical assessment in neurogenic. This is what the guideline says, right? You remember I told you that I modify the guidelines according to my patient's need, and in my daily practice, day to day, any patient with a sign of neurogenic, neurological, he's a candidate for urodynamic for me if he has avoiding symptoms. And I will tell you why. It's not just because they're not paying it, and it's free in the government. But why do I do urodynamic for all those patients? Because I believe that this is basic investigation that they need to go, and it's important for them. Sorry for that. Here they mentioned, يعطيهم العافية ما قصروا, وقالوا أن consider urodynamic in selected patient. What I say, consider urodynamic for all patients with neurological disease with avoiding symptoms. And again, when we go into the specialized management, they put urodynamic for all, and they added one thing. Preferably to do a video urodynamic, not urodynamic العادي, neurological. And this is what I do for all neurological. All neurological, I don't do them a urodynamic, the conventional, I do the video. Because there are findings I'm looking at. And I will mention why I do urodynamic for those patients with neurological diseases. The debate, as we said, it will be there all the time. People will say, committees, guidelines, هنا, just 3 examples. Fowler et al., هنا British guidelines, French guidelines. They like each other أكيد. يعني always fighting حتى في guidelines. British, they mentioned that urodynamic is not necessarily usually in the assessments for those patients with neurological diseases, for neurological lower tract dysfunction. French guidelines, every patient should have access to a urodynamic examination who is neurological. فأنا more of French type when it comes to neurological lower tract dysfunction patient. You will find this debate all the time. That's why I'm saying you have to tailor your indication, and you make sure that once you have your urodynamic machine available in your office, just make sure that you practice it according to your patient need, not according to just a book or a guideline that mentioned. Do it only if this diagnosis. If you have this device, use it and make it accessible as long as you think that will help you to tailor your treatment modality and your management plan for that patient. If you are 100% confident that this will not add anything to me, I'm confident I'll do this treatment for that patient, this is what he needs, this is what he deserves, he doesn't need a urodynamic. خلاص, that's it. You don't need to do it. Again, as I said, we're talking about invasive. Don't ever think that Euroflow is among all this discussion. Euroflow is very basic. It's like urinalysis. So Euroflow is one of the basic tools. طيب, when we talk about summary, and again, this is very short. An indication, as I said, everything related to lower tract symptoms. احنا قلنا this is the only functional tool we have for assessing of lower tract function. So we're talking about every single disease that you can believe that it's related to lower tract. So in summary, all lower tract symptoms are among the indications. Patient with incontinence, patient with bladder outlet obstruction, patient with a neurological lower tract disease, painful micturition, recurrent infection, mismatch between findings and symptoms. Someone give me an example of this mismatch.
Patient came with stress from incontinence, so it's actually alright.
Okay, good example, but again, we need to see what exactly is the mismatch between the finding and the symptoms. يعني الآن, when I say finding and symptoms, this is true when I do the urodynamic. صح؟ يعني سويت لي urodynamic, I discovered that he has a detrusor overactivity, but he thinks it's stress incontinence. When we talk about finding and symptoms, we talk about the finding and symptoms of that patient before urodynamic. Another example? I'll give you another example. Patient comes to you with a prostate of 30 grams. Small. I'm sure you find this in your clinic every day. His flow does not match. He has weak flow, he has symptoms. You cannot tell that this prostate is causing this obstruction. So I have to investigate it. And طبعاً it depends on the age, but this is an example of mismatch. Another example of mismatch, a patient that you are expecting a neurological disease, as I said, and that he has, that you are expecting him, that he has retention. And patient will come to you with the findings of frequency, incontinence. He will come complaining not of retention, frequency and incontinence. Doctor, Anna, every 5 minutes I go to the bathroom. I leak all the time. I use diapers. What is the basic symptoms? Incontinence. صح؟ الفايندنجز اللي قاعد اشوفها does not match. It's what we call this? Overflow incontinence. طيب overflow incontinence, I have to see, is this bladder obstructed or it is underactive and this patient is leaking because of that? This is the mismatch. It's highly recommended in any patient with children with voiding dysfunction, those who have lower tract symptoms, that these patients need to go for a urodynamic study. again, an age group. So when it comes to age group, pediatrics are among the selected patients that they need to go for urodynamic once they have symptoms of LUTS. طيب, can anybody tell me why? ايش الهنت؟ ليش البيدياتريك specifically نقول highly recommended on those patients with avoiding dysfunction, they need to go for urodynamic. By the way, يعني this is like casual. This is one. There is no magic behind the يعني ما فيها كذا خداع بصري على make it simple, think logically. Again, this is one of the diagnoses, but why we say specifically pediatric? Thank you. This is one. Most of those patients with lower tract dysfunction, there is a high risk that they might have upper tract deterioration. This is number two. And when I say number one, you want to understand why I said this is number two. So those patients, they are at higher risk as an age group. Most of their LUTS, because it's an early age group, they might develop a deterioration of their renal function and damage of their upper tract. So you need to intervene earlier in order to tackle the problem and solve it before they deteriorate. طيب, what's number one? This is one of the findings that you see, but why do I need to do it? And I might see the animals, but why? Huh? Thank you. Again, thank you. I won it. أخذت الاثنين جبتيهم. الأطفال فئة they cannot express exactly what they are having. You come to me and you tell me exactly what. They will just come with the symptoms. Either they're crying, they have problem with the voiding, the family cannot interpret, and you cannot interpret, and they don't know what's going on. They just think that they have a problem. And the only maybe symptoms they will face is just crying. Or you find them they're having nicotiniuresis, so they cannot express. For those patients who do not, or they are not capable of expressing exactly what are their symptoms, so you have to have an additional tool in order to do your assessment better. So this is one of the reasons. So you don't want to wait for this patient. Oh, by the way, again, we're talking about real life. Most of those patients who come after 6 or 7 or 8 years from their childhood with a damaged upper tract, they are dysfunctional voider from childhood, they have problems, nobody discovered them, and they were ignored, and they could not interpret their symptoms.
I have a question. How can you deal with the pediatric age and the urodynamic study? You have to communicate with them, to come, they tell us that there's a diarrhea, infection. How do you
I'll answer this in the setup of the urodynamic. How do I do it? And we'll ask the experts there, how do they deal with it? Do you do pediatric? Come on. Well, I was just trying to ask you to help me with it. Yeah. Unfortunately, we have almost 30% of our urodynamic cases are pediatric. We deal with them their way, sometimes even if we need to do sedation, but we deal with those patients depending on the age and how to do it. But so I'll discuss this also during the presentation about how do I do it and the system setup. Pre-op. This means, if you remember in the guidelines, we mentioned assessment, conservative therapy, medical therapy. If failed, go to specialized. Specialized means most of those patients will go for surgery. يعني, I'm not changing the conservative. There are small percentage that they were not dealt with in a correct way, but most of this patient, they will go into a surgical intervention. Now, is this an absolute indication or relative indications? Hmm? Relative. This is an indication for all possible cases that might need to go for urodynamic. Honestly speaking, and again, as I said, don't quote me on this. For me, there are indications for urodynamic, all those patients. In my practice, this is what I do. لأن those patients, you will have a combination that will guide us to the absolute indication. طيب, let's say أنا شخص أبغى أمشي جنب الحيط. I want to be strict, stick to the guidelines. I don't want to come tomorrow in the court with somebody complaining, why did you do aerodynamic? He got an infection and he developed a complication, and according to the guideline, this patient does not need aerodynamic. It's up to you. I have no problem with that. As I said, it's practice from one person to another. Doctor, just a few minutes ago, he was telling me, دكتور صالح ما عرفتك. حياك الله، كيف حالك؟ كيف الصحة؟ حياك الله دكتورنا، الله يعطيك العافية. Dr. Saleh, among our excellent colleagues, and used to be our trainee in Saudi Arabia, ونفخر بتواجده في فترة اللي كان موجود معه في السعودية. بس ما شاء الله جايب موسم حج كذا، بل ما عرفتك. طيب، الابسولوت indication اللي أتكلم عنه that we need to do urodynamic for them, اللي لما تروح الكورت they will support you with it. When you go to the guidelines, they will support you with it. لأن guidelines mention this clearly بالخط الأحمر. Before second operation, what does this mean? We were discussing, do I need to do it before prostate surgery or not? The guidelines, they say no. If there is a patient with a BBH and an obstructed, you don't need to go for urodynamic, go ahead and do it. I mentioned, I do it for all my patients. But guidelines say, you don't need to do it for all patients going into BBH surgery. And I have a big debate. It's a big presentation. But let's say stick to the guidelines. طيب, I stuck to the guideline. Patients underwent TR. Patient persist symptoms. كان عنده difficulty voidings. I did a prostate of 60 gram. I did TR completely free. Patient still having difficulties. What happens? And by the way, I attended 3 or 4 in just last few years. في عندنا في السعودية we have what we call it المحكمة للقضايا الطبية في شيء المستشفيات الحكومية والخاصة. فبحكم أن أنا في مستشفى حكومي فأكون مسؤول عادة في المحكمة حقت المستشفيات الخاصة. The area where the physician has no support at all, in those cases, if the patient file a complaint against that physician in the court, he did another surgery and they did not benefit. He did a prostate, راح سوى ultrasound, they found 20 gram prostate, he did cystoscopy, he thought it is still obstructed. You know what, let's go back, I'll go and do another surgery. You still have a small residual of prostate, I'll just tackle it and resect it. No, this is not the way you do it. You have to do a urodynamic. وكلهم خسروا القضايا بهذا السبب. لأنه they go and they think, you know what, I did not go. Unless, let me again make it clear. طبعا for me it does not make a difference, and as I said, I do urodynamic for all patients going for a prostate. Like, unless I have a prostate of 150 gram, and it is a bland staged TUR. So I tell the patient, we'll do first surgery, I'll resect part of it, and in 6 weeks, 3 months, 6 months, according to the plan, we'll do another surgery. This is completely different. In my practice, I already did aerodynamics, so there is no harm. But we're talking about a failed surgery. The same thing apply for stress incontinence. تيجي تجيب فيميل تسوي لها سلينج بروسيجر. والسلينج بروسيجر According to the guidelines حسب القرآن اللي موجود يقول لهم والله there is no indication to do a urodynamic for stress incontinence. Again, as I said, I disagree with that, but let's go with the guidelines. طيب, I did a sling surgery, failed. Doctor, you mentioned إنه والله المش جاي على إنه stress وطلع عنده transfer activity. She did not express the symptoms well. She said, جاتك بعد العملية, I have incontinence, I still leak. When I cough, when I sneeze, I still leak. Did you do urodynamic before that? No. Okay, sorry. I don't have the findings to say what was your abdominal leak point pressure. I don't know what are the data. ما عندي فيديو, ما عندي شيء. أنا دخلت وسويت لك العملية وأنا أعمى. عشان ال guideline they told me this. But anyhow, now I need to go back. What shall I do? You might tell me, okay, there are findings that you might say this patient has 1, 2, 3. They might have fistula. They might have failed of procedure. That's fine. This is part of the differential. But shall I go without doing a urodynamic and assess this patient before? Absolutely not. So before second operation, never try to do a procedure for this patient before doing a urodynamic. إذا ما عندك جهاز اليوروديناميك, لا, don't be heroic. Send it to a physician or a surgeon or a center where they have a urodynamic. Don't do a second procedure for a failed first procedure before doing a urodynamic in a patient with the lower tract symptoms. Clear? Second, risk of upper tract damage due to lower tract dysfunction. Once there is a risk for upper tract damage due to symptoms of lower tract, this is an absolute indication to go for urodynamic. Let's go back to the game. You remember I told you in our guidelines they say preferably selected patient suspected neurological lower tract disease, you do urodynamic, preferably to do video, صح? Pediatric age group, we say it's a relative indication. Why I told you I do it for all pediatric, I do it for all neurological, not in selected patient. Anyone can exclude a patient that has a neurological lower tract disease or a pediatric age group with lower tract symptoms, and they can mark them in one category as this is a definite patient that he will not have or she will not have an upper tract damage. Can you swear on this? Bottom line, even if the guidelines say that this is, as I said, there are a lot of politics plays around. And again, I'm not pushing you to do it. I'm just, again, probably يمكن Dr. Saleh, he knows that, but he did not join at the beginning. As I said, this is like a practical workshop. So we're trying to combine theory with the practice. As I said, when it comes to the, لما نقولها احنا باللهجة الشعبية, لما تقعد تفنط كل سبب واحد, you will reach up to the final conclusion that you have to do urodynamic. But going into the general كده sentence, that don't do it in those patients. Prostate surgery, they don't need to do it for prostate surgery. Unless, 1, 2, 3. You go and investigate your patient specifically, 1, 2, 3, you will find them under this category, that those patients fit into. They come and say extreme ages, elderly, young age group with obstruction, or if this patient has a weak flow and small prostate. And if you go into your practice, you'll find, Jama'ah, this is most of my patients. These are the patients that I deal with. Not anymore. We don't get anymore those simple cases. They're all complicated cases. So that's why I say, by the end of the road, you'll do a urodynamic. So that's why we're not doing it just because fun or because we want to do more and more studies. We believe that those patients with lower urinary tract symptoms, if you have the urodynamic device, you have to go and do it. So if there is a risk of upper tract damage from lower tract, don't hesitate and do a urodynamic. And as I said, before going for another procedure. So this is, you have to memorize it by heart. We came back to the, I think this is the last part before the morning session, and then we'll have a discussion and sum up with the presentation from the company. We discussed some theories at the beginning of the workshop. Had some indications. It introduced us about what's the history of the urodynamic, the definition of it, and what are the indications. Now, we need to understand some terminology. Then there are some terms that is connected to the urodynamic itself. Probably you don't need to memorize all the terms that are available, but the more you understand those terms, the more, if you remember at the beginning in the morning I said, al-mar'u aduwwu ma yajhal. If those terms you are not familiar with, then you will feel that this urodynamic test is not really helpful to me. I do not understand it. But if you understand those terms, you will be able to feel that this is a really very helpful tool for me. The non-invasive urodynamic, as we said, Uroflow. I'm missing one slide here, but anyhow, it's one of the uroflowmetry is one of the urodynamic modalities, if we consider it, or we can call it a simple non-invasive urodynamic test that is basically to assess the flow of the patient and give you an impression of the lower tract symptoms. But it misses what احنا قلنا earlier, what is the difference between it and the urodynamic? The pressure. You add pressure to the uroflow, صار full urodynamic. This is probably one of the things that I teach it to all my residents in the clinic. Time يكون difficult and we have a lot of patients with the uroflow. So probably this is the only message I can convey it between the busy clinic and tell them, memorize this and you don't need anything else for the uroflow. The uroflow is simple. But again, it's a flow, it's a pattern. If I give it to you and you have no clue what is it, بيكون again يعني tough, and it's very simple tool and you'll get a lot of information from it. The moment you understand how to pick up those information. If you get a uroflow, these are the data that you need to look at up and check. ما في شيء ثاني بيجيك في الورقة. You will have a lot of information. Forget about it. Take the stressors. First thing you need to check is what? Why? صح؟ احنا نمشي بالترتيب صح؟ First thing I need to look at, first of all, before I do my judgment on the stressors, I have to look at the volume. If it is valid volume, I will validate the test. I will go ahead with the next step. If the voided volume is like 40 cc, 20 cc, why do you need to bother? X is not valid. Go and repeat it. Okay? Shape, again. By the way, we put it in a way that you have to, again, go into this rank. One is the voided volume, second is shape. Although everybody will say, Euroflow, I need to go and check the maximum flow rate. Okay, maximum flow rate is very important, but go with this rank. Shape, why do I need to look at the shape after the voided volume? I removed all the numbers, huh? I just showed you a shape, and that's it. First impression counts, صح? First impression, before looking into all the details, bill shape, nice, wallah, this is normal, مباشرة. Then you go into the details and look at the numbers. Very striated, كذا, plateau flow, you'll put in your mind. Obstruction, تعلمنا, إذا plateau very long, it's a structure. If it is like starting with a little bit of high flow, then take a elongated voiding time, it's a prostate. It's a hint again, but it will just give you an impression. هذا will help you in order for assessment. After that, you made sure that it is valid. You already checked the shape. Now you look at the most valid key tool into the Euroflow, which is the QMax. لأن ال QMax هو اللي بيصنع الفارق في موضوع الأسسمنت. And I think I put in one of my slides the numbers, but in order to make sure that you will receive it, even if we reach to that slide, we might pass it, but I will mention it to you now. There are numbers, we will consider it normal or abnormal. Maximum flow rate is the best tool to assess your initial or your follow-up post-treatment response. Patients on a post-prostate surgery, or he is on medication, you will assess his maximum flow rate and see. Post-void residual. The post-void residual, forgive me by putting it under Euroflow, but these are the four, missing the post-void for Euroflow, tests will be not really complete. You will have كده picture that is not completed, الimage ناقصة. And that's why in some centers where they have a Euroflow, but unfortunately they don't have a bladder scan, or they don't assess the residual, you will get the data missing. I know he voided 150. It's 12 or 15 or whatever. كم الرesidual in order to say that this is good or not good. Anyhow, if you get these four, you got 90% from what you need in Euroflow. So don't forget when you check a Euroflow to check for those four things. If you got those numbers and you understand and you know what are those numbers, then you're good. What is the valid voided volume? $150 and more. Why? Why? ليش 100 ولا 50 ما تنفع؟ تعرفين ليش؟ الشركات كلها منهم. The companies, or طبعا this is joke. The physics made the device validity and the accuracy of the results related للvolume. it's related to the volume. إذا الفوليوم اللي الجهاز اللي هنا اللي موجود اللي نحط عليه الفانل patient will pass on it. If the volume, because either it's transducer that will record the velocity or the weight. If the volume is low, the validity or the number accuracy is interrupted. The studies showed that once it's 150 or above, it's more toward the accuracy. This takes us to a very small, let's say again, practice. Again, as I said, we'll try to be more practical. If I get 140, I will say this is not valid, go and come back. احنا قلنا validity will be affected, which means if it's 20 cc, we know that it's very hardly affected. But 140 or 150, more or less close. فاحنا لما نحط الcut off 150 and above, this is the standard. طبعا you weight this the way you find it, will patient follow up, will patient finding, and you see is this valid or not. فلما يكون close to 150, again, this is definitely not the 100% valid, but it's close to the normal requirement. Shape, as I said, most of the shapes that will have this 1, 2, 3. The bell shape, this is the normal, what we call it prostatic enlargement obstructed shape, or the urethral structure plateau shape. This is there are a lot others, interrupted, due to the abdominal, but this is the most common shapes. QMax, المساعة قلنا 150 صح؟ Connected always يعني try to make sure to memorize easily, to connect the numbers and be close together. We will go into the details, what is exactly the maximum flow rate depending on the age and the gender, male and female. بس خلينا نقول ناخذ الرقم الكومن المشهور. What is it? What? 15. 150 شيل الصفر صارت 15. 15 ml per second. This is the cutoff between normal and abnormal, with the details that we will speak later about it. بس below 15 we are talking about some abnormality, unsatisfactory. ما بعد نقول not normal. Above 15 we are more toward normal. BVR كم؟ Why? Okay. Any other suggestion? There is a slide about BVR. We'll talk about it, but here, consider 100 is the cutoff limit for you, if it is below or after. And again, we'll go into the details, what exactly the post-void residual, and when do we consider it normal or abnormal. بس خلينا نقول quick reference 150 bell shape 15 100. These are the quick reference guide for your Euroflow. طيب انت حاط لي اثنين بالاصفر وما تكلمت عليهم، شنو جايين يعني يتفرجون ولا average flow and flow time. Again, this will be in your slip in the Euroflow. What's their significance? What's the importance of it? I will rephrase. Without this, you're done with almost 90% of what you need from Euroflow. يعني ناجح وبامتياز بعد. You're done. You passed. Let's go into the spice شوية. Details. I want to go into more details about Euroflow. Let me get more benefit from the Euroflow. خليني أدخل بعض الأرقام. في أشياء أرقام ثانية. Time to maximum flow, avoiding time average. برضو اخترت منهم اثنين وضفتهم وشفتهم يصنعون الفارق معي. average flow وفلو تايم. ليش تفرق؟ وايش يزيد عليها؟ What does it add for me بالنسبة للفور؟ and when؟ طيب. Roaming around the answer, and there is no wrong answer, by the way, in this. And as I said, this is, and again, you will not find this in the book, لأنه this is one of the tailored practice that we feel this is the best that you get best of your Euroflow. شوفوا نتكلم على very simple test ها ويتسوى بالهبل, and we don't know that we can get a lot of data from it. It's just a Euroflow. طيب. Excellent. All correct. طيب. How do you use it? I use it for specifically, in all patients, but specifically for follow-up. Sometime, patient will come to you, طبعا post procedure, post treatment, whatever, for follow-up. Sometimes those number does not change much. يعني you will get 12, 13, 14 plus minus. Okay? ادخل في الديتيلز شوية. You go into the average flow, you will find that previously he used to have a Q max of 15, but it was obstructed لأنه طلع 15 وظل obstruction for a minute till he void and empty his bladder. الافريج راح يكون مجموع الفوليوم على التايم. فتشوف الافريج كان 5 4, although he came up with a 15 ml per second, which is considered normal. طيب البيشنت is still complaining. طبعا انت you will assess patient symptoms. But again, كيف أنا utilize this urodynamic Euroflow tool to the best and to the maximum? Let me take these small spices. Average flow. I see that patient had an average flow of 5. Now it became 10 ml, 8, 9. It improved. يا عمي السيمتومز حقتك تحسنت، مبين ما شاء الله عندنا في الفحص. It's better. تحسن متوسط تبول. Usually it come up with this one. Both. عشان كذا أنا حطيتهم. الافريج ومعاهم الفويدد تايم. What is the normal voiding time? Average flow, by the way, there is no number for it. I put 10. Usually it's 10. This is the good. مثل ما قلنا 15 and above, 10 and above. But again, as I said, it's an assessment tool. I use it for follow-up. فما تفرق معي كثير. بس usually I put 10 ml per second. What's the flow time? الوقت. كم الوقت that patient will need, normal patient will need to pass urine? ها؟ أكيد less than a minute. Normal, 30 second normal. طيب قسموها this way. 20, 40, male and female. Normally, everybody should pass urine and finish by 20 seconds. Male, especially more elderly, يعني after the 40s, usually they will take a little bit more. Anybody less, احنا ايش قلنا? Within 20, you should pass urine. This is خلينا نقول the best, idealist. What is the cutoff number? 40 seconds. Anybody less than 40 seconds, considered normal. Anything more than 40 seconds, again, questionable. And that's why when you do a follow-up, you will come patient with a big prostate enlargement. He received the treatment, and his flow time was 2 minutes. قاعد في الحمام for 2-3 minutes in order to void. Even his flow initially is good, but he was like taking his full time in order to empty. After treatment, you'll find his flow time come back to a minute or 50 seconds. Is it an improvement, or we'll say this is abnormal? It's an improvement, more than 50% improvement. So again, as I said, this is one of the best tools that we assess and it will help us to make sure that we really utilize very simple, small Euroflow test. I'm slow, fast, أموري أوكي؟ تمام. هذه الأرقام اللي بالساعة كنت أقول لكم عليها. More than 15 to 20 cc per second is considered normal in men. Less than 10, abnormal by all means. Anything below 10, خلاص. There is no negotiation. This is abnormal, your flow. You have to investigate it. 10 to 15, equivocal. What does equivocal means? Again, I will tailor my patient. يجيني very elderly patient, his flow is 12, he's 80 years, 75 years, his flow is acceptable, residual is low. I will consider it acceptable and I will just follow. I don't need to go, you know what, your flow is not perfect. Yeah, we know that. But below 10, definitely there is a problem. Women, it should be more than 30 or more or less 30 cc per second. Do they all have this maximum flow? Do we consider it in the clinic as 30 as the cutoff limit for females? This is the suggested numbers. In our practice, as I said, 15, we consider it normal for male. If the female is more than 15 but less than 20, it will be the same when we say in men 10 to 15, and if equivocal. More than 20, usually I consider that this patient is normal. But 30 is the ideal. Anything more than 20 in female, usually I consider them normal unless they have symptoms, if they are symptomatic. طبعا guidelines suggest that these values will decrease with age by 1 to 2 cc per second per 5 years. يعني كل سنة كل 5 سنوات تنقص 1 to 2 cc. These are factors that might interfere with the results. Time of the day, psychological inhibition, voided volume. زي ما قلنا voided volume يفرق معايا. It will make a difference if it is little or if it is a lot. If patient, and this is one of the mistakes that we do, we ask our nurses, they will just instruct the patient, don't come to me unless you are fully full. And you will have 10 patients waiting, they are all full. And they will be waiting there, super full, double full. They will come at the voiding machine, they cannot void. And they will come and fight with me. Your nurse asked me to be full, and when I came, she said, you have 10 patients before you. Wait. And this will affect the result. Day of the procedure. If he's early morning, during the daytime, afternoon, he had lunch, again, it will affect. It's a functional, it's a dynamic. So you have to put this in consideration. Sometimes I ask my patient, if I don't see an explanation and he's happy, he's satisfied, he's fully satisfied, but I see a real difference between this Euroflow and that. Probably it's still normal, but this is different from what we did 6 months ago. Abu Flan, anything different? No. بس المرة الماضية يا دكتور جيتكم الصبح وكنت محصور و I passed urine. Today I came to you after lunch. I already had my activity. So this is my normal at the afternoon. So consider the timing that you do the test when you assess and look at your test. Residual urine volume, as I said, you cannot complete it without having a residual urine volume, otherwise your picture will be incomplete. Either by catheterization or ultrasound. Ultrasound means bladder scan. Unfortunately, it's a very small, simple tool. We don't have it everywhere. This is really a problem. What we really believe that it should be by ultrasound, bladder scan, basically because it's just an assessment. It's difficult to put a catheter for all patients to assess. Otherwise, they will skip from doing Euroflow. And it will turn into an invasive test rather than an invasive. احنا كان نقول simple non-invasive. Catheterization is an invasiveness خلاص. It's preferable just to do it by an ultrasound, bladder scan. There is no need for catheter unless patients are undergoing urodynamic or test, or this patient is already using a clean intermittent catheterization or using a catheter for a reason or another. Normal BVR, مساعة, what numbers did they give you? 100. In 100 is خلوها cut off كذا. What is the normal BVR? Huh? It should be 0. We should have no BVR. المفروض you go and empty your bladder 0. خلاص. This is the normal. But we know that everybody might go and still have some residual limited. That's why we say, ليش specifically we said 100? Why did we say it should be 0? Why did we say 100? We'll go into the sensation. No. Study suggested. Again, لما نحتار نقول study suggested. Study found that the risk, شوفوا, always lower tract, يعني رغم big function that they would do, and everybody will complain if they have a problem with the lower tract. Unfortunately, lower tracts are just servant for the kidneys, for the upper tract. وظيفتهم خدام مساكين، حماية للكلية. إذا الكidneys find another way to save themselves, your lower tract is gone. You don't need them. For voiding, their main issue is to preserve your upper tract. You don't want to go into impaired renal function and renal failure. طبعا quality of life is different, but we're talking this is the main function of the lower tract. Studies suggested and found that residual of more than 100 ml, patient will be at higher risk of infection and upper tract deterioration. So that's why they put a cutoff. Type. Is this very clear cutoff? No, it's a controversial. You will find books writing it as a 50 ml. You will find books writing it as an elderly patient, for example, related to age. Percentage of bladder capacity. شلون؟ Percentage of bladder capacity for residual. يعني I have an elderly patient. He is being obstructed and has a prostate enlargement ولا diabetic, and his bladder capacity is 1,000 ml. Will I compare him with a normal person with a bladder capacity of 400 or 500? His bladder capacity by default will come up with a higher rate of avoided residual or post-void residual. So the suggested percentage, which is related to normal, لما نقول 100, ال 100 من ال 500 تطلع كم percent؟ ها؟ 20%. صح؟ 100 من ال 500 is 20%. So just convert this percentage into a formula, the volume into a formula of percentage. So we're talking about a 20% of the bladder volume. If you know that this patient has a bladder volume of 1,000, you will accept even the 200. I really missed one slide, but anyhow, the slide was talking about the types. And I don't know why I don't see it here. Probably it's among all other slides. We'll see. But Euroflow, we mentioned it's among the non-invasive urodynamic. Post-void residual is number 2. We have the other types of urodynamic, which is the cystometry. Filling cystometry, voiding cystometry or cystometrogram, then urethral pressure profile, EMG, and video urodynamic. these are the phases of normal cystometrogram. الآن دخلنا في invasive urodynamic. There are 4 phases. Cut it short. Summary. 3 phases related للfilling cystometrogram. 4th phase is the voiding. First, initial rise of pressure. طبيعي, normal. This is at the initial. Later on, we'll have what we call it tonus limb. Stable pressure, elasticity of the bladder is good. There should be no increase in the pressure, minimal increase in pressure. This should be most of the test will be on that phase, which is the tonus limb. Number 3, rapid rise in pressure. الفيلنج خلاص وصلنا بدينا البريض اللي يقول أنا exceeded my limit, I have urgency, I'm already full, please stop the test. You will find an increase. And that's why it's very important when you want to assess compliance. لا تروح لي في آخر شيء last 2 seconds and you measure, say, the pressure, the compliance is no. Take a real represented trace of your urodynamic test. So these are the phases of the cystometrogram tracing, where 1, 2, 3 related to filling, number 4 is related to voiding. We will look at the findings of the filling and voiding. There are 9 C's. We need to look at شكلك عرفته. لا ما يصير تقولينهم لا. I need them بالترتيب. هم 9 صح؟ We call it 9 C's of the cystometrogram. 5 related للfilling and 4 related للvoiding. What are the filling phase? Capacity. Capacity is 1. This is one of the things that you assess. صح? Compliance. The compliance is what? Delta volume or difference in volume, difference على the pressure. كم normal? Compliance. Always put examples in order to memorize. Volume average 500. Pressure should not exceed 20. صح؟ 500 على 20 كم؟ 25. 25. This is normal. طيب pressure if it is really low, really normal, it's 10. 500 over 10, 50. This is normal. طيب لو كان pressure is high, what numbers you remember إنه في pressure يكون high؟ 40 صح؟ في رقم كتف يجوا يقول والله 40 أزيد البريشر. طيب if it's 500 خلينا نقول 400 مو 500 عشان التقسيمة. 400 over 40 يطلع 10. This is impaired compliance. ف 10 or less is impaired compliance by all definitions. 10 to 20 is an equivocal. More than 20 is considered a normal compliance. فthis is related to the elasticity. Again, تذكرون قلنا يخدمون الأبر تراكت. إيش الأهمية حقت الكومبلاينس؟ What's the importance of compliance? The more impaired the compliance is, there is a high risk of upper tract damage. Again, we go back to what we mentioned. It's the upper tract that we need. The more impaired compliance, this patient, and that's why one of the most important measures that we need to assess in those patients with the neurological. Compliance is very important. If the compliance is good, sometimes I change my management plan if the compliance is good. If the compliance is impaired, I'll go for surgery, Botox, neuromodulation, augmentation, whatever, but because the compliance is impaired. It's connected heavily to the upper tract. Core sensation, desires. Contraction, stability, or if there is a detrusor, overactivity. Continence, which is leak. فالخمسة اللي 5 C's that we have in filling cystometry are those. Capacity, compliance, what else? Sensation, which is course. طبعا حطوا الكورس بس عشان تصير C. Fourth, contraction and continence, which is leakage. But this is in order to memorize it. Remember, bladder outlet obstruction cannot be assessed during filling. You remember we said? ما تشوف الديتروزر under activity. Again, bladder outlet obstruction, you cannot assess it لأن bladder has to be relaxed during this phase. So we're not checking obstruction. Sensation, very quick. احنا نتكلم على terms. These are the terms that you have to be familiar. The ladies are very familiar with it during the procedure. You have to explain to the patient, and we will talk about it when you talk about preparation and the patient instruction. First sensation, first desire to void, strong desire to void, and maximum cystometric capacity and urgency. The first sensation of bladder اللي هو the sensation when he or she first became aware that the bladder is filling. وبدأت تصير يعني أحس بدأت مثلا تتعبى. This is almost not more than 50%. نتكلم على it has to be less than 200 ml. 120, 150, 170 is still considered normal. If it is more than 50%, we consider the first sensation is abnormal. Clear? First desire to void. The feeling that the patient would desire to pass urine at the next convenient moment, but voiding can be delayed if necessary. I need to go to the bathroom, I'm doing my presentation, I can wait. Still more than 40 minutes, 30 minutes, I think I can wait. I don't need to interrupt the presentation. This is the first desire. I don't have any urgency. I have no fear that I'm leaking urine, nothing. I still can wait. It's almost 75%. And here we talk about a 200 plus. اللي هو 75% إلى 300. اللي احنا كلنا على النورمال اللي هو من 400 إلى 500. We consider normal from 400 to 500. From 2 to 300, this is the first desire. I might pass, but I still can wait. Strong desire to void. لاحظوا the difference between this and this. Strong desire to void during filling cystometry as a persistent desire to void without the fear of leakage. I have very strong desire. I need to go to the bathroom, but I'm still confident that I won't leak. I need really to go. أنا خلاص المثانة, the bladder is really full. But I can wait. I mean, I can hold. I will not leak. This is almost 90% من bladder capacity. Maximum cystometric capacity in patient with a normal sensation. This is the volume at which the patient feels she can no longer delay micturition. خلاص. I cannot wait anymore. This is the maximum. Leave me, otherwise I will pass it. بس هنا تدخل في المرحلة الأخيرة اللي هي الurgency. The sudden compelling desire to void at any time during the urodynamic. Which means this might happen at the maximum cystometric capacity and it might happen any time during the first. أنا first desire ما عندي شيء. بس all of a sudden I felt the urge that I need to pass urine. I did not reach to the strong desire ولا maximum all of a sudden, which could be related to detrusor overactivity or related to any incidence or provoking factors. This is what we call it the urgency. في أي لحظة خلال during the procedure. it has to be, it has to be, and this is considered as the maximum cystometric capacity. And see here, no longer delayed micturition. You have to differentiate between leakage and the urgency. Leakage يعني أنا وصلت full, where it will go? I will pass urine. If that's it, خلاص, that's it. This is the maximum. This is not the urgency. This is the cystometric capacity that you reach to. The urgency, it's the sudden. يعني أنا feel that I'm really full. I can't wait, but all of a sudden I feel that I'm leaking. So this can happen at early stage, at the mid, or at the end of the procedure. Capacity زي ما قلنا up to 500. في البيدياتريك أحد يعرف المعادلة؟ We call it Koff's formula. Any pediatric more than 1 year, up to 12 years, you cannot say they are 500 ml. Again, in order to practice, put an age. عمر 8 سنوات. 8 years plus 2, 10. By 30, 300. This is the volume. 4 years. 4 plus 2, 6. 6 by 30, 180. So almost 200 ml. طيب, what about those who are under 1 year? Sure. This is another formula that you calculated. Pediatric age group. We have very limited number that we do them under 1 year. But 38 plus 2.5 times age in months. 10 شهور 25 plus 38 يطلع almost 60 ml. 70 ml. Okay? ايش الفرق بين functional وماكسيمم cystometric capacity and anesthesia maximum capacity? These are the definitions زي ما قلنا, huh? This is the definition that will help you to understand more your LUTs, your voiding and your urology specialties and the urodynamic parameters. هذه كلها definitions that are connected to the urodynamic. What are the difference? Functional bladder capacity, maximum cystometric capacity. أعلى واحد فيهم شنو؟ تتوقعون؟ ها؟ لا. Under anesthesia. الفانكشنال that is the normal bladder function اللي هو patient desire wants to void. 300, 250, 350. This is the functional. This is my functional, the time that I feel that I need this desire to void. Maximum cystometric capacity during the test اللي هو خلاص full, and usually very occasionally you reach this during your daily practice. عادة ما تصبر, مو كل مرة يعني تخلي. This is not your day-to-day practice. You don't do it. Maximum anesthesia bladder capacity, patient is under anesthesia. So you can double the size and the volume of the flow inside. So it can be doubled. يعني 500 ممكن تصير 700. So this is the highest. So you have to differentiate. Maximum anesthesia bladder capacity, patient under anesthesia, whether general or spinal or epidural, and the bladder will be fully flaccid. فهذه تصير شنو؟ الانستيزيا. هذه الاناتوميكال. يعني هذه البلادر في حالة الارتخاء الكامل اناتومي. الاناتومي حق البلادر قديش يوصل؟ 600 700 800 اناتومي بس ريلاكس, ما في عليها لا بريشر ولا نيورولوجيكال افكت ولا بيشنس افكت, ما فيها شيء. خلاص under full anesthesia, spinal or GA. This is a common urodynamic equation. You remember I told you don't memorize them? This is just for you to know that this is equations that are available. الجهاز قام خلاص, the machine is getting them out. Flow rate, difference in volume and a difference in time, not pressure, volume on time. قلنا volume على التايم. الكومبلاينس difference in volume على pressure. normal compliance قلنا مساعة صح؟ قلنا كم الرقم. the trouser pressure لما أحط الكاثيتر اليوروديناميك I put in the rectum or in the vagina, right? This measures what? Abdominal pressure. When I put it in the bladder, I measure what? So I don't measure the trouser, صح? In order to measure the trouser, I have to use this subtraction formula اللي هو الآن الجهاز measure it. يحسب لي الفيزايكل اللي هو الفيزايكل the trouser pressure of the bladder and the pressure of the abdomen combined together. So I have to subtract the abdominal from the vesicle to come up with the trouser pressure. If I have a vesicle, you remember when we say single channel, we used to get the vesicle. بس give hint, but other parameters that are affected does not help you with that. So this is the subtraction, and again it is automated, and this is where you consider more the findings. That's when we say pressure trouser. في طريقة ثانية we measure pressure trouser. Other way to measure it other than this. في المختبرات شو يسوونها؟ needles. If you go into the trouser pressure, رحت على the trouser muscle and you put needle and measure it, but we do it in urodynamic? You cannot put needle, and how can you in labs? They can do this if they want by checking the pressure directly from the. Well, this is when I speak about the EMG. I'll tell you why I don't like to do the EMG. طيب الفسيولوجيكال فيلينج ريت وسالني اياه الدكتور من ساعه قبل ما يمشي كان عنده ارتباط for cystometry. This is a formula. I don't really follow it, but this is one of the formulas that there. Body weight per kg divided by 4. يعني patient has 70, I divided by 4 تطلع around 25. This is the normal. هم حطوا المعادله يقول لك هذا النورمال around 25. But what are really the normal filling or the standard filling that we do? We'll mention it. These are important for you to not to forget, and this is again one of the things that when you do the reporting you need to check, and this is something that helpful for your diagnosis. Leak points. We have the trouser leak point pressure, and we have abdominal or valsalva leak point pressure. The trouser leak point pressure, see the difference. This is the lowest trouser pressure at which the urine leaks around the catheter in the absence of the trouser contraction and increased in abdominal pressure. يعني ما فيها abdominal pressure increase وما في trouser contraction normal. This is the lowest trouser pressure that happened and caused whether leak or contraction. This is the trouser leak point pressure اللي حصل فيها leak, sorry. When it leaks with a trouser pressure that was not supposed to be there, trouser overactivity, and it leaks, this is لما يقول لك trouser leak point pressure. الآن يجيك trouser pressure, right? You have parameters and you have multiple trouser pressure, different trouser overactivity. طيب, what is the trouser leak point pressure? السيستم كيف يحسبها? How does it count it? You have 6 trouser overactivity, all leaked. أي واحدة اللي بسجلها trouser leak point pressure? The lowest one. يعني ليك على 30, ليك على 50, ليك على 40, بيشوف the lowest, and this is what we consider as the trouser leak point pressure. طيب, if there is an abdominal pressure there, false. There has to be no abdominal pressure. مش ضغط من البريشر من الابدومن, لا, we are talking about the trouser pressure. طيب, abdominal leak point pressure, this is where the abdominal comes. lowest intravesical pressure, intravesical. You remember we mentioned abdomen زائد detrusor equal vesicle. Lowest intravesical pressure at which the urine leaks around the catheter during an increase in abdominal pressure, but in the absence of detrusor contraction. هذه absence of increased pressure of the abdomen. Abdomen leak point pressure, this is for detrusor overactivity. This is for what mainly? Stress incontinence. This is for stress incontinence mainly. So if there is a leak because of an increased abdominal pressure, but the detrusor is normal. There is no detrusor abnormality. And there is a leak in the there is an increased abdominal pressure. لأن احنا قاعدين نحسب abdominal نحسب شنو الفيزايكل intravesical pressure اللي هي abdominal plus detrusor. Let's say the detrusor is 20 and the abdominal is 70 at that time, and كم الفيزايكل تكون 90. 20 plus 70 90. So we'll consider the abdominal leak point pressure or vasalva leak point pressure at what? 70 or 90? The lowest intravesical pressure, so it will be 90. And it helped me to count the abdominal pressure, but the number that I'm calculating is the intravesical. This is the abdominal leak point pressure. If the detrusor pressure is 20, abdominal 70, the vesicle is 90. 20 plus 70 is 90. So the abdominal leak point pressure at which there is a leak was 90. If I consider this as 90. Detrusor leak point pressure, less than 40 centimeter. You remember I told you a number. Huh? Again, من تشوفوا الرقم محطوط في اللور tract, and if they put it as the standard, the reason for it is what? Huh? For what? Why were they saying 40? احنا ساعة قلنا 100 وكل ساعة نجيب رقم ونقوله. ها؟ شو تقول study؟ upper tract قايل لكم هذول خدام حق الابر تراكت حق الكدني. They are just serving the kidney. يعني the kidney is the queen and they are their servant. More than 85% of those who develop more than 40 detrusor leak point pressure, they will develop an upper tract deterioration or damage. So it has to be less than 40. If there is a detrusor leak point pressure that's higher, you have to intervene. If it is less, you can go with the conservative therapy. Abdominal leak point pressure, although personally, this is just personal, I don't 100% rely on it, but this is the standard numbers. If it is less than 60, usually there's intrinsic sphincter deficiency. Between 60 and 90, equivocal. More than 90, it's urethral hypermobility. Why I don't believe much in it? Doesn't make any difference in my treatment. If it is less than, I put it less than 120, less than 100, I discuss with the patient the success rate of the sling procedure. If it is more than 100, 120, there's a higher success rate. If it is less than 100, 120, there is a less success rate. لما نترجمها in the words, this goes with the intrinsic sphincter deficiency. But this is the standard. If it is يعني كل من صغر الفالزافا leak point pressure أقل, it's more that it is intrinsic sphincter deficiency rather than the hypermobility. طبعا ايش الديفرنس في التريتمنت؟ في intrinsic sphincter deficiency sling procedure does not work. Success rate يكون حقها low. That's why. But standard wise, worldwide now, treatment options are the same. You do them sling. Potential causes of falsely elevated valsalva leak point pressure. يعني ليش يطلع البريشر هاي رغم انه it's not normal؟ يا يكون في cystocele, or patient is very anxious, she's holding her urine, or larger catheters. الكاثيتر موجود blocking the leak, or lower volume in the bladder. ما في كمية من لها فيطلع valsalvic point pressure as high. This is one of the artifacts that's affected. Or inability to strain. The patient herself cannot strain. It will just give you that the valsalvic point pressure is high, although she is not straining even. Pressure flow study. Evaluate bladder emptying by measuring the detrusor pressure and urine flow to differentiate between low flow due to obstruction versus poor bladder obstruction. We need to add video urodynamic or sphincter EMG to identify the location of the obstruction. يعني pressure flow study الآن احنا نتكلم على voiding phase. It will tell you. بس قلنا 5 صح؟ الحين 4. بيعطيكم خبر على الكونتراكتيليتي coordination complete emptying والclinical obstruction. Bladder emptying voiding it will tell you if the patient is emptying complete emptying عشان تصير C فقالوا complete emptying. وcontractility is it احنا اول كنا ندور contraction detrusor overactivity abnormal. احنا نبغى نشوف contractility here it's normal. If there is a contractility or no. If it is underactive or no. Complete emptying الcontractility coordination. ايش معنى coordination؟ شنو نبحث عنه؟ detrusor sphincter deficiency اللي كنا dysynergia. لما نقول ان في dysynergia between the sphincter and the bladder, so there is a coordination issue. This is you assess it during voiding, not during filling. And clinical obstruction. طيب clinical obstruction you will get it by the voiding cystometry. But can you tell, as you said, prostate or structure? No, you cannot tell. Either you do an EMG, you make sure there's a problem with the sphincter itself, or do a video and assess the obstruction and see is it at the urethra level, is it at the prostate level, if you want to. Normal volumes, as we said, for BDET, it's 40 to 60 centimeter of water. الwomen usually 20 to 30. هذا في الvoiding during الvoiding. وهذا those are the parameters that you will consider during the voiding cystometry. اللي هو prematuration pressure, all related to pressure. And this is funny. Sometimes people will do a urodynamic and they consider they did a filling voiding cystometry, but when they ask the patient to void, they will remove the catheter and ask the patient, go void. The moment the patient remove the catheter and ask him to void, what did you convert the urodynamic into? Uroflow. There's no pressure. So if you do the uroflow without a pressure, it's not a voiding cystometry. But when you ask sometimes you ask an officer, no, we do voiding, but we remove the catheter. How can I ask the patient to void while the catheter is in? No, you have to keep the catheter. This is a pressure way of assessment. Anyhow, so maximal detrusor pressure at maximum flow, as post-maturation closing pressure, they are all pressure. If you don't have those catheter end to assess those pressure, how can you get all those numbers? And by the way, those numbers, you don't write them. بيجيك again في السيستم مطبوعة. You just select them and put them in the report. Normograms, again, in early years when we have those tests, we used to memorize them. Now it's all in the system and it comes يجي shape في الurodynamic في الريبورت. The most important اللي هي accredited by the international continence societies are those. You have just to be familiar, especially for the resident, they have to be familiar with it in order for the exam. AG nomogram اللي هو أبراهام جريفيث, this is usually pressure detrusor QMax ناقص 2 QMax. يعني pressure detrusor 40 QMax 15 أو 10 40 في 10 400 ناقص 2 QMax ناقص 2 في 10 20 يطلع this number يطلع 300. This is obstructed, this is obstructed. ففي nomogram you will get it in a plot in the diagram and will tell you. Shaver nomogram grading of degree واصل إلى 6 grades. Just to tell you detrosal contractility, degree of obstruction. And you have the group specific erythroid resistance factor nomogram, YCS provisional nomograms, وthis is bladder outlet obstruction index اللي معتمد على ابرام جريفيثs. Again, this is the formula: pressure detrosal Qmax ناقص Q2max. إذا أكثر من 40 it's obstructed. إذا أقل من 20 it's non obstructed. In between دائما يحط لك الاكويفوكال. وبتشوفوها in this diagram. Bladder contractility index BDET Qmax plus 5 Qmax. If it is more than 150, means bladder contractility index is good. This is a strong contractility. If it is less than 100, weak contractility. If it is in between, it is equivocal. So those are the tools that you use. And again, machines are equipped with it. Usually, you will just put a BCCI or so. They will tell you this is the. But for exams, for you as a resident, بيجيك في exam, you have to memorize those formulas. Video Urodynamic. Yes, yes, it is BDET Qmax موجودة في البارامترز موجودة. ده يمكن عندي أحد السلايدز فيها I will show it to you, but if not في الجراف you will have BDET Qmax. Which machine do you use, Labori or which one? Huh? Germany. Okay. But you have a table at the third page that will show you. Not the graphs. This is the Abrams Griffith. The numbers, like BDET, maximum flow, they put the numbers. Leak point, you'll have a table. Yeah, so there is a table. Usually it's with all machines. أهلا كيف حالك حياك الله. يا جماعة, this is a summary and I have another slide with 10 findings in the video aerodynamic, but this is the combination in one. Video aerodynamic, bladder contour. يعني when you do a video aerodynamic, these are the findings that you will get. There is nothing come out from these findings. You want to check the contour of the bladder, either there is a bladder filling defect, if there is trabeculation, if there is a diverticulo, if there is a cystocele. You want to check for a reflux, vesico-ureteric reflux. You want to check post-void residual. You want to check the bladder neck. Is it closed or open during, and you will see probably some cases and films where during the filling, is it opened funnel during the voiding? Is it an indication that it is an obstructed at the area of the sphincter or not? Check the urethra for stricture if there is a diverticuli or fistula at the urethra. These are all the findings that you will get from the video. If you are looking into any of those, you need to do a video urodynamic. EMG. Sphincter EMG, it will help to evaluate the serrated sphincter complex. لما تنحط ال EMG patches or needles, it will just specifically will help you and direct you to see if the sphincters are working or not. This is the function of it. Most important information is determined whether there is any detrosal sphincter dysynergy or not. Okay? The other way to do it is video. صح؟ احنا قلنا نشوف بالفيديو if we can get it. Video is more applicable, more informative, and give you more data, and at the same time, more reliable. The problem with the EMG, you have to do it either by needle or patch. What do you have for EMG? Do you have EMG here? You have both. You use needle or patch? Or you have both?
Normally, they use
batch. In Saudi Arabia, they use batch. Everywhere. What's the problem with the batch? The problem with the batch, the accuracy of the reading. You cannot get an accurate. You remember when we say that you have to get a needle into the detrosal muscle to measure the pressure? The same thing. If you want to exactly measure, we did this study in Toronto almost in 2006, and it was hell to recruit patients, to ask them to put the needle, 2 needles in each at the anal. It's hell. And I cannot recall that the patient will accept to do. It's again very invasive. But we were doing a study for the posterior tibial nerve stimulation, and we had to do it this way. We could not recruit really good number. The problem with the batch, hair, movement, the batch will move, and you'll get a lot of artifacts, a lot of faulty results. That's why you cannot rely on it. Urethral pressure profile. Urethral pressure profile, again, it's one of the graph. Basically, it's a machine. It will pull, it will assess the pressure inside the urethra. And it will give you, automatically the device will pull this device, draw in the urethra, and will في pressure sensor. This pressure sensor or the catheter during the length of the urethra will just assess the pressure in each area of the urethra. Why they use it? They use it to assess the resistance, especially in patient resistance of the urethra in patient with stress urinary incontinence, to see is there a hypermobility or if it is resistance in the urethra. What is the limitation? I don't do EMG. I don't do urethral pressure profile since more than 15 years. The problem is the limitation in the test is not because they're not good. I could not rely on them in assessing my patients. So usually I go with the video, easier. بعد 15 سنة, again now the studies started to be very controversial. The ICS standardization subcommittee concluded almost, I think, 15 or 18 years, إنه الurethral pressure measurement is not clear. يعني يا جماعة UPB does not add a lot to us. So that's why in most of the centers worldwide, they don't use it. Mostly they are using it as for studies and for experimental. In practice, usually we don't do it. It's 11:18. Now, either we do this very quickly. You need 15 minutes, right? Or more?
What I have to speak about the system or how to set up the system, some trouble, some tricks for...
I have a presentation about the tricks, but you know what? I'll do that. Allow me to be quick. يعني الآن we need to wrap up before lunch and before the break, so you can do the presentation. And I think I have to present this to make it easy for you to present about the system, how to do the system, because part of it is the system setup. How do we do the urodynamic? In 30 minutes, if I can. We'll just arrange the pre-procedure preparation, patient preparation, position, and system setup. This is the pre-procedure preparation. We had a form in Arabic for our patient created in our unit about why do we need to do this test, how to prepare yourself, what you are expected to do during the procedure, what are the precautions, and patients to sign on it. This is a consent that we tailored in our urodynamic unit. Usually the nurse or the practitioner or the physician will call or discuss after coming, will come from my clinic to the unit to get the appointment for urodynamic. So they will just interview them, give them appointment, usually we give them this paper in the clinic, and the nurse or the physician there will explain to them little about the procedure. And usually we do it even in the clinic. Review the allergies, and again, it's part of the paper, and medication, anticholinergics to be held 7 days. Controversial. But if you want to get a result of a normal urodynamic, you have to stop the medication 7 days before the procedure. Sometimes patient cannot, so no worry. Just let them continue on medication and do it. Why? Because I am doing the test in spite of patient having a medication and he's not really responding well. So I want to provoke and assist the function of the bladder even with the patient on medication. So guidelines suggest you have to stop the medication before, but in practice, usually we don't, since patient will usually use the medication. Review of risk factors, pregnancy, mobility, joint replacement, because your patient will be on immunocompromised, whether to use antibiotic or not, voiding status and patient to be consented, voiding diary usually 3 to 7 days before, 3 to 7 days voiding diary to assess and bring it, and this will help you also to assess the capacity, see how much you fill the bladder during the urodynamic. So it's always important to have a voiding diary before doing a urodynamic. Urine culture prior to testing, preferably catheterized specimen. This is usually a neurological patient or patient who has difficulties, but usually it's a midstream voiding. And in our practice, we do urine culture for all our patients before urodynamic. In the guidelines, unless patient high risk, suggested, you need to do a culture if there is no symptoms. Yani patient come to me, has no symptoms, she or he is asymptomatic, has no problem, we go ahead and do urodynamic without urine culture. What we do in our practice, we do both, which is, again, as I said, controversial in the guidelines. We do a urine culture and we give antibiotic prophylaxis. Antibiotic prophylaxis is not in the guidelines, it's not necessarily unless patient has a specific indications. The coverage for prophylaxis antibiotics, usually patient with a neurological or suspected or immunocompromised, or if there is risk of any septicemia. What we do? I do one thing, again, it's from my mind, 5 days. 2 days before, third day, 2 days after. People give prophylaxis antibiotic on day of procedure. People don't give antibiotics, no antibiotic at all during the urodynamic. Some people, they give antibiotic at the day of the procedure and continue for 3 days. My practice, 2 days before, third day they take the antibiotic again, do urodynamic 2 days after, complete the 5 days. Patient preparation, complete history and physical examination. Location has to be quiet, clean, and private, because again, you are simulating the process of filling and voiding. So it has to be a little bit more privacy. If you put it in this room, doing a urodynamic here, and there are 10 of patients around doing tons of tests, how can the patient do the urodynamic in a really comfortable way? Treat all active infection, this is a must. If there is an infection, especially for neurological, even the guidelines, they don't say don't give antibiotic or don't do urine culture. In neurological, this is a must, because again, it's a complex and it is high-risk patient. We're talking about normal. For neurological, even the guidelines. For us, we do prophylaxis and urine culture for all patients. Autonomic dysreflexia. See this? Ask the patient what is your most bothersome symptoms. Guys, this is something that you have to do it with all your patients. You don't want to be in different pages with your patient. If patient is coming here to be treated for nocturia, and you're looking into the detrusor overactivity, he doesn't carry anything about this, he doesn't care about it. Treat his nocturia, see what is his most bothersome symptoms, see what he's really worried about, and explain it to him. Otherwise, next day, patient will escape. Patient did not come to you to treat a graph or to treat a picture or an ultrasound. He came to you to treat his symptoms. So you have to share the data clearly with the patient and explain to him why you are doing this. Autonomic dysreflexia, ليش we put it? ليش all of a sudden we put a diagnosis, autonomic dysreflexia? You know what is autonomic dysreflexia? Again, just because of time, autonomic dysreflexia is one of the highest and biggest emergency in urology. And you don't want to have autonomic dysreflexia during your simple urodynamic procedure. You will give this poor lady a patient, you ask her, go and do urodynamic. She feels that this is a very simple test. I'm doing it, I'm leaving, going to my lunch. All of a sudden, patient had a blood pressure of 300 and collapsed and had intracranial hemorrhage. Death. You got my point? It's up to death. So imagine you're doing a urodynamic and all of a sudden the patient died. Why? This is specifically in patient with, حتى في الdiagram محطوطة على الwheelchair. This is specifically in patient with a neurological disease. Because of the deficit at the level of the T6 and 8 and above it, you will have a lesion. This will cause an acute autonomic disorder that patient will have an acute reaction to an acute stimuli. In this exact position, what is it? Filling the bladder. So during filling of the bladder, the patient will have headache, sweating, flushing, blood pressure will shoot, they will have bradycardia. Once you see those signs when you do the test, you have to do one thing. What is it? Stop and do what? Drain the bladder. Stop, put a Foley catheter, drain the bladder. You will remove the causing factor, then you go and give the treatment accordingly. But usually the moment, and we had it and so patient, the moment you empty the bladder, things will relax. But if there are very high risk patients, there is a history, you come to you and he said, and I get autonomic dysreflexia, I get this agitation. Whenever my bladder is full, I get sweating, I get headache. You don't need to, انت احنا ويجلنا will provoke what happens outside, but you don't want to provoke a real test that will really cause a problem to him. So it's better to give him a prophylaxis, nifedipine, or give him even IV sometimes treatment if it is necessary. But you have to be aware of what is it. You don't want to be surprised. Oh, I have a patient, all of a sudden sweating, blood pressure high. You don't know what is it. So you have to memorize what is autonomic dysreflexia. You have to put it on your urodynamic room. There, big sign in red, autonomic dysreflexia, how to treat. If you tell all your staff, once you have any patient with this, remove, put a catheter, you will save almost everyone. Position. ICS stands for what? International Continence Society. Standards, they say, uroflowmetry and post-void residual plus urodynamic, which is transverse cystometry and pressure flow study, all tests are performed in the patient preferred or most usual position, comfortably seated and or standing if physically possible. ساعة قاعدين يقولون على راحة المريض. Then they say, but you know what? It's better that we do it in a vertical position, standing or sitting. Whenever possible, pressure flow هذا في الفيلنج. في ال pressure flow study usually seated. عند الwomen وبعض المن وعند المن if they prefer to go standing. So it's a mixture of your comfort and the recommendation. Overall recommendation to do your test sitting or standing, filling or voiding. What we do in our practice, most patients, they don't like it. So unfortunately, we do it. طبعا they want it lying. This is the worst thing you do. Supine. So what we usually do, semi-sitting. نجهزهم in a supine, then we put it in a semi-sitting close to the sitting. In Canada, the chair will not allow you to do semi-sitting. Ilzami, it's a chair, it's connected from Siemens. We put a belt, the patient automatically will be in a sitting position, it will do the practice as a sitting position. So we do it in a semi-sitting. Usually it's like 45, 60 degree, and ask the patient to do the test. This is important. Also, I was telling one of the doctors. Why we're putting this, and this will be, I will leave it to gentlemen here to say why this is movable, why we're doing it, why it is movable, why it's not fixed.
Because you have to set the position to the...
It will destroy all your tests. If you don't Patient is sitting, and you did all the position according to the level. It's 0 level. Where is the 0 level? Symphysis pubis. He's in sitting in symphysis. Then you do test, patient standing. You do not change this. خلاص. All tests destroyed. 40, 30 degree difference. You will see all the tracers that I will show on one tracer. All the tracers are like completely destroyed. You will not get any information. So you have to, that's why those transducers are movable, because you have to fix it. This is vital tool in order to make sure that when you do the zeroing and you do the test, it has to be at the level of the symphysis pubis. Make sure there is no air bubble. Especially نحن طبعا air bubble نتكلم على الwater, not air catheters. Filling cystometry, normal saline. This is the normal that we usually use. Use a contrast if you want to do a video urodynamic or if there is any further indication. Men standing, as we said, women sit, but usually we do it in a semi-sitting position. If there is a physical disability, they may have to lie and be in a supine position. Speed and degree of bladder filling. How much should you fill to? Catheter movement, importance of good taping. بحط الصورة الآن. Rate of filling. And I don't know if the electrical shock last 3 slides, I don't know where are they. There are 3 slides about the types, I don't know where are they, honestly. They disappeared. Filling, the normal filling. 50 is the standard. As I said, we do 50. Less than, you remember I told you weight divided by 4, which is almost 20. So usually it's within the range of 20. Slow filling rate. What is the number of a slow filling rate? Slow filling rate. When I ask you, please do the test under a slow filling rate. What is the slow filling rate? 10 ml per second. 10 ml per minute. This is the slow rate. You can't go more or less than that. 10 is the slow filling rate. When I give you a recommendation, do it a slow filling rate, this means 10. Degree of bladder filling. Usually we are approaching up to 500. ما يحتاج توصل 1000, even if the bladder capacity is there. Every time you ask the nurse, give me another saline, another bottle of saline. No. 500, this is just interpretation, that's it. If there is a loss or leakage, you might go put another bottle in order to add for 200, but you don't need to reach to a full capacity. خلاص, you reach to 500, there is no sensation or whatever, but you don't need to fill the bladder up to 3000. Taping is important. You have to do the taping in a very correct way. If you put the taping here down, it will affect his flow. So you have to make the taping and up, so the patient, when they void, and make sure that it is fixed, and when they void, the tape will not come in between. And also, when you put this is either this way or the other way. When you put it at the back, you put tape at the glans, but make sure that it is not tight, because if you make it very tight, it will be like obstruction, بيقفل الurethra. The same thing for the abdomen. Make sure that you put tape to make sure that it does not go when the patient strains. Flush line to remove the air. Place transducers to refer a reference level مثل ما قلنا. Zero pressure. Always make sure that you zero. When you zero at what level? At atmosphere. You don't do zero level inside the bladder. When you connect and open, you have to make sure that it is open and it's at the atmosphere level. If you put it inside the bladder, you will get wrong results. Check quality control. Quality control, رئيس قسم الجودة في اليوروديناميك test. This is the chairman of the quality department. Cuff test. Cuff, normal, good, go ahead. There is a problem with cuff, you don't start. Cuff, we have errors, you don't start. This is your quality control. This is your safety officer. Without a cuff test, you don't go and you don't proceed. Start recording and proceed accordingly. Again, as we said, we're blessed that the new devices, they just give you, it's like monkey business. 1, 2, 3, go this, do this, do this, do this, but you have to know and understand your business. It's not like before. Yes, 0 level. Okay. You said you're familiar with urodynamic. When you say set it 0, then you charge, then you are using air catheters, صح? Air catheters out, set 0, charge. Don't charge. في الفluid, it's outside. We don't call it charge. It's outside, atmosphere level, zeroing. When it is air-filled catheters, في trick. It's outside. You do the zeroing, then you flick it. When it is open, this is atmosphere level. So you zero, then you charge. Resting value for abdominal pressure. وبنشوف بعض السلايدز. When it is supine, your expected abdominal intravascular pressure يكون على 50-20. You will see one of the artifacts لما يكون pressure high. To start with, again, when there are increase in the pressure, you will not be able to assess it. Sitting 15-40, standing 30-50. ولما نتكلم على pressure detrosure لازم يكون at the level of +5 -5. Usually I like it to be always positive. But I start with a detrosure pressure of 30. No, it has to be 0. +-5 is okay, acceptable. But don't start with 30 because the difference, it will give you the difference. If it gives you this high difference, you have to assess your catheters. Make sure either the abdominal is too much pushed, or if there is a problem with the catheter kinked, or whatever there are, we will discuss this in the troubleshooting. But you make sure that the detrosure is 0 ±. Resting pressure should not decline during the test. يعني لما نقول resting pressure 20 حق الابdominal ما يصير ينزل كذا. If it dropped down, either the catheter slipped or there is a problem, artifact. Again, we'll talk about it in the troubleshooting. Cuff are used as a regular interval. 1 minute, 50 ml, whatever. But just make sure you do this cuff test, as I said, quality control all the time. Filling rate, 10 ml per minute. Is this the slow, physiological, what they call it? Medium, 10 to 100. Fast, more than 100. Without that, fast is applicable to patients. We cannot do it because really it will provoke abnormal detrosor activity. So, as I said, we do it at 50 ml per minute, and children and patients with overactive require slow filling rate. So usually children goes with 10 ml per minute. Clear? Voiding cystometrogram. When do you let your patient void? Voiding position depending on patient, try and avoid straining. متى أقول للمريض to void? When I ask the patient to void. You're Mr. Doctor? Massimo. I asked him, he said, because of the position. So when the patient moves, usually I'll do the adjustment. I'll not ask the patient to void. I'm holding it in the system. So I'll ask the patient to stand and make sure that all the assessment and measurement is good. Then give the patient, you will find it, probably this is here in the same thing in the system, permit to void, right? You have this, permit to void. Permit to void, then the system will start recording again. Because you have to hold it you finish the filling phase. Now you did not give the permission to void. So don't finish filling phase and give permission to void while the patient is still not ready. So just make sure that there is a communication with the patient. Consider catheter size and risk of causing an obstruction. Size is usually 6, 8, usually 6 in pediatric, usually 8, sometimes 10, but we usually standard as 8, French. And cough test pre and post void, always use it. Consider residual volume. Make sure that if there is a risk that there is high residual, and usually what we do, we put a catheter, empty the bladder, and make sure that it's there. Or if you have the bladder scan and the patient empty, and usually we do Euroflow, free Euroflow, before we do urodynamic. If there is a high residual, we empty because it will affect the test. Tailor the test. Expected cystometric capacity from bladder diary. Blood diary that I got, I know that his voiding functional is like 300. So I don't fill it to 600. I know that within 300, 300 plus, 400 maximum. So I tailor it accordingly. Voided volume expected. From what we have seen and what patient had before, I expect what is the voided volume, which كثر how much I put there in the bladder. Supine to fill the overactive bladder, just to relax it more. Void position, as we explained earlier. Filling speed change. What do you mean by filling speed change? I put it 50. طيب, it's not Quran. I put it on 50. Now I start to see that the patient compliance is really impaired. I cannot do the test. Lady, put it down to 20. If it works, then well and good. If not, I know that his impaired compliance, I respect. But I don't insist that I will do it 50, I respect. This is the normal, but I tailor it accordingly. Running a water as a provocation. Some patient will come to you, I'm normal. But if I hear water, I start symptoms. افتح الحنفية وشوف صحيح تصير عنده عشان you know it is normal, but there is a detrusal of provoked overactive bladder due to leak or due to water noise. Or cold, you change the temperature. Stress testing if required. And if there is a stress test you want to check, especially for ladies, you do the stress, coughing or crouching while exercising, وcheck فالز alpha leak point pressure. Remove all catheters after you end the test. Empty residual if using contrast media, especially إذا كانت more contrast, patient can have the rest, no problem. Explain result for patient and remind them of symptoms for UTI. Again, this is part of the explanation that we mentioned at the beginning with the paper. Fill out the report and make treatment plan. Post-procedure instruction, this is what we tell the patient usually. This is for the nurses or the doctors. We ask them, please take your antibiotic today as prescribed. Drink almost 8 to 10 cups of water over the coming 2 days just to make sure that you flush. You may have irritation, that's normal. You might have some blood, that's normal. If you develop any temperature more than 38, please come to our office or come to the emergency. Call the office if you have any other further notes, and usually there is a number for that. And your next scheduled appointment will be at that time. This is the instruction we give the patient after he finishes the urodynamic. Maintenance of the equipment and calibration, I will leave it to the gentleman, but you have to make sure that we do the maintenance and calibration on the basis that is usually required and recommended by the company, the manufacturer. If there are water that they will say you have to check the transducer every 4 patients, right? You have to change it every patient. You have to do the calibration every month. Whatever the recommendation is, because it will affect negatively your result. I'll give you 2 minutes. Some variables that can affect CMG, calibration, filling media, as we said, cold, that will cause irritation, filling rate if it is very high, catheter size if it is large, that's causing obstruction, and we'll talk a lot about it in the afternoon session. Presence of massive post-void residual. That's why you have to make sure that you empty the bladder. Presence of outlet incompetence. If there is a fistula, there is an area, there is an injury at the area, if there is a fistula at the bladder or vesicle, this will cause a leakage. So this will be a default of the CMG result. Sum it up, interactive part, your time. Before I start, this is my message. Don't forget, صح? Don't forget this. I will leave it here. Massimo? We have at the end of the day, we have, depending on the time and if we finish early and depending on your time, I have a lot of, as I said, I put a lot of tracers. Probably it's my first time to see. And I will discuss it with you. I do not have time to review it all. Depending on that time, we'll just, we're not discussing every single case. We are just giving examples. I hope like the first or the first part of the course or the morning sessions were beneficial. You got some data, you got some information that will help you to understand more and be more familiar with the urodynamic. In the afternoon, what we will have will be more of troubleshooting, tricks and tips how to interpret the result. لأن احنا خلصنا الآن من indication والtest to finish with how to do the testing. Then we'll go into how do we interpret the result, what are the troubleshootings that we'll face during the interpretation, and after the interpretation, those interpretation need to go into paper. So I have to do a urodynamic report, how to do a urodynamic report, and then we'll end up by having some case discussion and finish inshallah by group photo. Massimo, I think you can give us an introduction before a prayer to the system. I gave some introduction theoretically about how we prepare your system, probably the catheters that I mentioned in the presentation. What are the catheters? What are the abdominal catheters that you use? And give us an introduction about your system. Okay. Can we, I think we are few, like we're not a big number, so you can come closer. If you are all come together, you need it for the recording, right? You need it for the recording? So here you go. Massimo, here you go. For the...
If we have time, we could use this at the end of the course.
Sure.
Okay.
You want to show it now? We have last hour, it will be like case discussion. So we can start by the simulation.
Okay.
After
Or probably when we speak about the
troubleshooting.
troubles, yeah.
Sure.
Huh? Okay.
Just make sure that my slides are not interrupting. I don't know why I messed up. We don't need this now.
I try to connect.
Can I connect it?
I think. Okay. So, very compliment to the doctor. I saw one of the most interesting course of urodynamic in my life. Really. So, just to ask you, all of you are making urodynamic test, or is the first time you see urodynamic? All of you are using urodynamic, right?
They have different experience. Some of them are using it frequently, some of them new residents who just introduced.
Okay, so later we will talk about the trouble during the examination, because I'm not a physician, I'm a technical. So I will give you some support about how to exit from the trouble during the examination. Now I want to show only how this unit works during the examination, okay? So, first step is to insert the name of the patient, which is done directly writing here. It doesn't matter if the patient already came or not, just writing the name of the patient. For example, now I write my name and surname. Oh. Okay, as you can see, the name is not into the database, so the software automatically created a new patient. Then I have to give just few information as the patient ID, the birth date, and the gender. That's all. Then I have to confirm the patient, which I want to do the examination, and the name appear here on the top. Then we have to select the examination we want to perform. A free flowmetry, cystometry, it's a void in cystometry, and flow pressure or urethral pressure profile. We can see, for example, the flow pressure study, which is the most complete examination. Okay, so we start directly from the left to the right. It's very simple. The button that you can use, it's on, or the other that is not working are off. So the first step is balancing. What does it mean, balancing? Is the phase when you check if everything is connected well and your connections are working well. So in this phase, you press balancing. The device shows you exactly what is happening without recording nothing. So you can do everything now without recording. In this phase, it's very important to set the transducer, the catheter, to fill all the lines and everything. In this phase, for example, as the doctor told to you, is to put the catheter inside, fill the line, then ask the patient cough, and until you have not the same response between the vesicle and the abdominal, don't continue, because the examination will be okay. So in this phase, balancing, not recording, absolutely. So you can play what you want to do. I don't know if it's connected now, the unit is filled or not.
No, they're not.
Oh, okay, something there is, okay. So this phase is just to set up the machine, okay? What is important? I saw, as I told you, I'm a technician, not a physician, so I saw a lot of examination in my life. Most of the examination are done with the zero inside the bladder. So they put the catheter and they make the zero inside the bladder, which is wrong. Wrong, don't do it. So you have to put the catheter inside, then you have to open the stopcock to tell to the machine which is the zero that the machine has to measure. It's really simple. Look at the stopcock. It's a 3 ways. In that position, you put in contact the transducer with the catheter. Okay? So in this moment, the device will measure the pressure inside the patient. Okay? If I want to make the pressure, the atmospheric pressure, I have to put in contact the transducer with the atmospheric. So I remove this cap and place the stopcock like this. So I open this way with the transducer. The important is the height of the transducer. Now, so I have to place the height of the transducer exactly where is the position of the synthesis, okay? Now, after that, you see that the pressure changed, and I have to press the zero button, okay? Then close again, and ask the patient to cough again. So, only when the two pressures, the vesical and the abdominal, are at the same level, I can start to record the examination, okay? So we press the start and ask to the patient to cough immediately. This is to prove that the machine is set well. So if another doctor will see your examination after you, he knows that the setting up of the device was making well, okay? Okay, after that, you have to start with the pump by pressing this one, as you see. The pump is working, okay? And now just putting the marker, the ICS standard marker, first sensation of bladder filling, for example, first desire to void, strong desire to void, and bladder capacity. With bladder capacity, the pump stops automatically, but you can start again by pressing again the pump button, okay? So it's very simple. After that, you can say to the patient to void, and then you press stop. That's all. It's very, very easy. As the doctor say to you, every 50 or 100 millimeter of voiding, you have to ask to the patient to cuff, because sometimes they can lose the catheter. So if they lose the catheter, the examination is full. So it's very important during the examination to ask if everything is okay, and the cuff, because with the cuff you can control every phase of the examination. Okay? That's all. Then you have to save the examination stall. That's all. It's very, very easy. What I can say about these devices? This device is a wireless device, which has no cable connection between the patient unit and the computer unit, and is the only one unit that is using DECT wireless module communication. It's not Bluetooth. Bluetooth has a limited distance between the patient unit and the computer. DECT, you can put the unit 300 meters or on the upper floor. There is no problem of communication. And also, for example, when you go to the video room, you can put the devices, the patient unit, inside the X-ray room with the patient, and you can stay outside with the computer, because the DECT pass the lead wall without problem.
Allow me to stress on that point, because this is one of the major issues that we face all the time, which is the Bluetooth compatibility, and it might be one of the reasons that the disconnection will interrupt the study. So this is a very important, let's say, advantage of this device, although we don't have it in Saudi Arabia. But again, although we have like one of the very common, or let's say popular urodynamic machine worldwide, unfortunately, Bluetooth always has limitation, as you mentioned. And I have to stress on the other point, you mentioned about the zeroing. This is again for the fluid, where you make the zeroing at through the atmospheric pressure with the airflow. Usually it's what we call charging. Release it, charge it. But again, release is like exactly like the atmospheric. Once you charge it, it's again considered inside the building. So never do the zeroing at when it's connected and inside the bladder, because you will not get what you need from the
Yeah, you can make zero before charging the casters.
Yes.
Then charge casters.
Yes.
So no need for
This
zero
is for
again.
air.
Yeah, no need for zero again for after charging casters.
Listen, you will need zero every time you feel that you have a problem. This is part of the troubleshooting that we do.
Yeah.
But never do zeroing
Outside.
because some people, they will be, you know what, it is negative all the time, you know what, make things easy for me, do zero.
Mm-hmm.
It doesn't happen. It does not work, and that's wrong.
Mm.
And this is one of the, you don't want to do the test just for the sake if I want just to do the test.
Yes.
Either you do it correct, you ask me, right?
Yeah.
When do I need to repeat it?
About what
Yeah,
position?
when you ask me about when do I need to repeat this.
If
You don't want to repeat. The test usually is invasive, and the patient does not like that. Every time you ask me, you know what, there is a mistake, there is a problem, I have to repeat it. There are some people, some physician or some doctors, it's their habit. They don't trust the device. They want to repeat the test 2 or 3 times for the same patient, the same session. I don't want to say any other words. But the only word I would say, this is really stupid. I mean, if it's me, I'm the patient, I will just kick your catheters and leave. Doing a test that you ask me that will take 30 minutes or 45 minutes, sitting with me for 3 hours just want to repeat, you are really provoking, you are destroying my bladder. You want to make, even if the bladder is normal, it will be abnormal. So There are few indications that you need to repeat the exercise. I think there are one of the slides, but as I told you earlier, unless there are a real malfunction that you have to repeat it and start over again, but you don't want, I know that there is a trend that people, they finish the test, you know what, it's normal, you know, I have to repeat it again, change the flow, change the setting. No, this is not the way. Sorry.
So, another point of this device is the modularity. All the module on the back, as you can see. So, if something happen to the devices, the assistance is very immediate because the technical come and remove just 2 screws and remove the module and put the other one. With the other machine, you need to stop the examination, stop the activity, and wait until they bring the machine to the laboratory to check what's happened and repair and bring you again. With this machine, you can remove the module and replace with the new one and start in 2 minutes after the fault. Okay?
Urethral catheters.
Uh-huh.
You have rectal, and you have vesicle. Okay, vesicle usually it's in the, it depends on the age, so patient male or female. Female usually shorter, more than 10-12 centimeter, and you have clue. You just pull, aspirate, and see you will see urine, and you are in the right position. Usually for male, usually at the range of 20 centimeter plus. So this is where 20, here is 20. So I'll push it more till I feel that I see some drop of urine coming and I aspirate and see. For the rectal, again, you might find some resistance, but usually your catheters that you have pusher, right?
Yeah, you can insert and remain inside this.
But you have pushers, some.
You have still for it?
You have still it for that, right?
No, it's like this. You put inside with the insert with the.
And how you push the more? How you push it more? Like if I want to push it more.
This is the right length.
Yeah.
Insert.
Well, usually, no, but this is short for the.
شكله
But
كده
usually
مش
put
مش
like
شرط
more than-
تدخلها كلها
more
جوه.
than 10 centimeter in order to make sure that you avoid this anus sphincter area.
Shouldn't
So-
be the same level?
No.
No.
لا.
Where into the bladder?
Check.
Like the bladder and
you
the
mean
rectal. Like the same, like
Yeah.
if you insert 10, you do 10. If you do
شكله
15, you do 15.
You mean this one?
وتقف
Yeah.
زي الثانيه بندخلها 10 15 سم.
Hey, so usually, and why I asking because usually this is like you have a solid one that you can push it.
Yeah.
So usually we go
Like
like
this.
10, like this one,
Yeah.
10, 15 centimeter, and push it. Again, it depends on your stool impaction, if there is any resistance. And that's why I said you adjust and see if the pressure is good or not. If the level is okay, the measurement is good, and cuff test your quality is everything is good, that's fine. But honestly, what we do usually you push it with another one, so we go like around 10 to 15 centimeters. Usually.
You have a demonstration video for this one?
Can I ask a question?
Yeah.
All the catheters, including the
Pump tube?
bump tube, are they exclusive or?
No, you can use what you want.
Okay. Good. That's
Okay.
excellent.
Just to explain to you, this is the bladder and this is the rectal catheter. If you go up, compared with the bladder catheter, you can have a higher abdominal pressure. So you will have a detrussional pressure which is negative.
Yes.
So you have to pull down the abdominal catheter.
And
But
this
probably
is
we.
again, this is again part of the troubleshooting.
Yeah.
That's why I said you have to do the adjustment. Unless you are sure. You remember we said resting pressure, what's the pressure? You cannot start with abdominal pressure of 60 or 80.
Yeah.
So you have to adjust accordingly and make sure that it's going And the thing is, just make sure that you cross beyond the anal sphincter. You don't want to do the abdominal pressure testing like outside. You want the anal, because you want to assess the abdominal, not the anal sphincter.
Another thing is that this catheter is open catheter, which means, because I remember when I started to do urodynamic a lot of years ago, the catheter used in the past were the nasogastrical pediatric catheter.
They put the gloves.
Yeah, but at the beginning, without the gloves, only the catheter.
Yeah.
But the problem was the fecal.
Back.
Yeah, so they invented to put the gloves to the catheter to cover the point. The problem, which is with the balloon on the rectal catheter, is that if you fill a lot the balloon, you will have an increment of the abdominal pressure. So it's very difficult to calibrate the abdominal close catheter, because you have to pay attention if it's a pressure inside the abdomen, or is a high pressure due to the syringe filling. So
And
we
that's
have
why
this kind of.
nowadays we don't do the filling of the balloon. Even if there is a procedure, usually we snap it, we cut
Yeah,
it.
we have already cut the catheter, because this balloon has only to cover
Yes, just
to avoid that the fecal material go inside.
Nobody now does the.
This is very simple, one-way catheter, and you have no to lose time to remove, fill, remove. This is very, very simple. Okay, then I think we will explain with the doctor in troubleshooting how to do.
During the troubleshooting session in the afternoon or during the case discussion, probably you bring the
Simulator.
simulator and we can discuss it.
This
Yeah.
is an air or water machine?
This is water.
Water.
This is
Yeah.
water. The air is, you have the.
You can use also the
Yeah,
air, but
that's
we
also
don't
so.
recommend the air bath because we have we follow with the.
I used to be very resistant to air till like 6 years ago. You know, politics, Naburi.
Yeah.
They are the T-Doc
Yeah.
inventor. So they oversee all the market. So we started to use it. There are some limitation for the air, and I'm a fan of fluid. But nowadays we are faced with there are a lot of you have to do. That's why the company started to offer both, and that's why I get me to ask you. Can you use the same machine, air and fluid, and a different setup, completely
We
different
can use
machine
both. Yeah.
at the same time?
Yeah.
Okay, that's good. Because some other companies also, they don't, you have to change the full system.
Calculation
Yeah,
system.
yeah, they have both air and fluid, but you cannot use it at the same time. So we used to have MMS, you know MMS?
Yeah.
MMS was excellent to use it. Now not anymore because it's
Was bought from
bought by Labori. And Labori is pushing for
His system.
their system, and they push for the T-Doc, the air
Yeah.
flow, because they don't want the fluid anymore, because they are the inventor of the.
Yeah, but because they are the inventor, but now there are two or more
Yeah.
companies that are producing the charging catheter.
ICS recommendation, by the way, the international recommendations are
Using water filling.
like more of recommendation for water film.
Yeah.
As I said, advancement of.
Yeah, but this is because it's a physical situation.
Exactly.
The air is compressible, the water not. So if you have a pressure with water, you are sure that this pressure is like this. With the air, you don't know. A cuff with a high charged catheter is not the same level with a cuff with the water catheter.
So why do you use air before?
Why
is it used air? Why?
They're still using.
We don't recommend it to
It's
use
waterproof
the
system.
But if the customer want to use
Yeah, it's waterproof system. Approved system. The recommendation is, again, it's, as I said, company, and it's been studied, and they said it's this is possible. This is the advantage. This is the disadvantage. And by the way, I found the two slides that were lost. I don't know. I'll show you that number. And this is like the same discussion when we say, why don't we use the ambulatory urodynamic? It will be much easier. Like when we do cardiac cardiac monitor to check the cardiac status 24/7. There are advantages and disadvantages, but it used to be like till 8 years ago, fluid catheters are like the dominant. Now more and more, as you said, more companies are using it. So we don't have
But probably now Lebori will decrease the use of it.
Thank you so much. We'll have a break for Dr. Talat. 15, but ها خلاص؟ ايه ها؟ طيب. Just before we start, خليني على ما find my slides. Where did we reach? I got the reason. Okay. طيب, how was the morning session? قديش نقدر نقول you got some information that might help you in your practice and in your حتى your study for you as a resident? Good. Excellent. And I just want to stress, and again, one point, I keep mentioning this every time I do the urodynamic course or workshops, depending on the sessions that we do. My aim is to connect it as a practical as much as possible, rather than having any. We have tons of urodynamic books, and there are a lot of urodynamic books that are really good, but you can read them today. If you read it, and I ask you, go and practice it, do the urodynamic, you'll get lost. So the aim of this course, basically, again, you need to practice, you need to do more and more cases, but if you get like what we call it as like the more like a high priority, or what are the key secret, it will help you to understand the aerodynamic more. The afternoon session, again, it's more like of a practical, probably will share more and more traces, not for you to memorize it, but to exchange some experience. I might be wrong. I cannot read all the traces. I might read traces in a way that, but we'll try to teach you how to interpret the traces in the right way. طبعا the slides, they were there, but I don't know why they were hidden. I found them in the this is just to complete a morning that there are the conventional and ambulatory, and the advantage and disadvantage between conventional and ambulatory. What's the difference? Quick. You see people doing ECG, or sometimes they could not record during the ECG the test, so they will give them monitor.
24 hours monitors to see if there are, like, especially those patients who will have missed beats, will يكون عندهم atrial fibrillation. Probably it's not there all the time, but it is really bothering them. So sometimes when they do the ECG on spot, they don't get anything. So they get the 24 hours monitoring in order to elucidate the signs at that time. It's helpful in cardiology because it's like this machine. Although في الfaulty that's related to الbatches, it might be give false results, but there are no catheters inside. So this is one of the main disadvantage of the ambulatory. وأشهر واحد موجود in the market, it's called Luna. But the ambulatory, when we talk about practicality, it's not practical to do for patients an ambulatory urodynamic, or at least for all patients. It has to be very, very selected. The main advantage of ambulatory over the conventional one, it's functional. The filling is functional. You don't fill the bladder. It will fill by itself. The catheter will measure. But the problem with that, there are catheter 24 hours. The patient will be disturbed. It's not convenient for the patient. And the default that are the faulty problems that either the catheter will go out or patient with the movement or something, they will have, you'll get the urodynamic report and you'll find a lot of artifacts that you cannot interpret it or read it. So this is the main disadvantage. The only advantage of the LONA ambulatory urodynamic, that it will pick up some signs that are not picked by the conventional one. طبعا fluid versus air, we already spoke about it. Single channel versus multi-channel. I don't think there is a single channel in the market anymore. I think all the aerodynamics, they use a multi-channel, right? Yeah, not anymore. It's not applicable. هذا طبعا تكلمنا عنه. This is the 9 C's that I talked, and again, this is important and it's easy to remember for you to know what we're talking about. Results interpretation and troubleshooting tips and tricks. After you finish the test, now we come to the next step, that we have to interpret the result. So I come, interpret the result, read it, prepare myself to go for the next stage, next step, which is writing the report. The objective of the interpretation, we have to identify the resting baseline pressures, understand their significance, recognize the artifact, determine where pressure measurement can be reliably taken from the trace, explore a systemic approach to trace interpretation within your scope practice. These words, in another word, in a different meaning, we call this a good urodynamic practice. When we talked in the morning, we have to understand the basics, your normal numbers. This is when we say identify the baselines and numbers, in order to make sure that you understand, in order to interpret. If you don't know the basic numbers, the baseline, you'll not be able to interpret that this is a normal, this is abnormal, this is because of that, or this is an... Again, artifacts, it's important, because if you got an artifact that might alter your results or alters your urodynamic findings, it's all about how I understand my basics, how I understand my basic physiological urodynamics rules, and I know my numbers, I know all the parameters that when I do the test, I will check them. Then I can decide whether this is normal or abnormal urodynamic. So this is called good urodynamic practice. You can Google and check either in the ICS website or in any of the international guidelines. You'll find a free paper that you can download it from the web, which is good urodynamic practice, which is written by one of the highest ranked, distinguished in their field, in the field of urodynamic. The magic slide, huh? Again, just to remember and remember and remember. Interpretation. شوفوا لما اتكلمنا على البيسك we got this. لما اتكلمنا على preparation والsetup we brought this. Interpretation, definitely we need to bring this. لأن with the interpretation you are talking about the filling, voiding, and you're preparing yourself to interpret what is. So don't forget this slide, please. What is this? This is an example. طبعا again, I'm just showing some examples, some findings to familiarize with the tracers of the urodynamic. You might get it in the exam. It's important to understand, and we need to know. We'll try to end up by having the basic, how to interpret the tracers. شنو هذا؟ Can anybody tell me anything in this? Okay. هنا هذا. Thank you so much. لحقتي صدتيها. You got it. Whenever I give you anything or you see a tracers, one of the most important point in the annotation in the good urodynamic practice is the annotation. Annotation means the trace or the test is annotated. Everything is written. When you have the cuff, when you have a change of the position, when you have an event, if this is filling, if this, it has to be, we call it annotation. If it is not annotated, the problem is, and this is what we face, probably the one who did the test is different from the interpreter, is different from the one who will write the report, is different from the last users who's the practitioner. I might be the same. أنا ممكن أكون the one who did the test. I did the test, I did the interpretation, and this is where it comes that you have to make sure when you do the interpretation, do it correctly for a reason. We'll go why. It will come in the slides. Why we need to make sure that we do a good interpretation based on what we find, because not all the time the one who will do the test is the same interpreter or the one who write the report. So it's good to know that this is, أنا المسج من هذا السلايد يعني thank you so much. I like your comment. And no, by the way, this is probably I don't know how many times I presented this. Every time we'll get the same. أنا يعني when you said that the trouser of activity, فكذا ابتسمت ابتسامة داخلية ابتسامة خبث إنه we'll have the same mistake every day. But when you correct it perfectly, this is the only thing I need from the slide to say, is this filling or voiding? And this is what I need you to do when you go to the exam. يعني during the test, you have it. You can't tell. But during the exam, I might trick you, bring you this, and tell you, what do you think? Oh, this is the trouser overactivity. I see that the trouser pressure is high, and there is a leakage in from the Euroflow. This is a leak here and here, and so this is the trouser overactivity with incontinence. Completely flip the coin. Okay, this is voiding. Oh, things change now. It's voiding. So this means this is a normal contraction, and it's high. This is the flow, So we change from detrusor overactivity with incontinence into bladder outlet obstruction. So annotation is important, and you might receive in exam, in one of your sessions, something similar to that, and the only answer you need to give to the examiner, and I'm assure you'll get a full mark, is this filling or voiding phase. And probably he will not ask you next, what do you see? بيكتفي بهذا الجواب. What is normal tracers? Keep saying, we have to understand what is exactly normal tracers. Resting pressure in the bladder, اللي هو abdominal plus minus 10 centimeter. Normal tracers, you remember we said when sitting or standing, or we'll see a slide. This is a normal tracers. So you have to make sure it's not possible. We mentioned this during the practice, and wallahi, if the abdominal lumen is deep inside, you might have high pressure. What you're looking at is to have 10 plus minus. Pressure of vesicle 30, 20 abdominal, 20, 10 abdominal, something like that, around. Not 60, 20. You will get the difference in pressure, you'll come up with a pressure of detrusor that is 40 or 50. You already started with an abnormal detrusor pressure. How can you identify abnormality in the detrusor? So pressure should be within the following range according to patient position. Supine 520 as we said, sitting 15 to 40, standing 30 to 50. Let me stress on something. You might go to a book and find the difference 10 centimeter of water, plus and minus. Yes, this is a statement of consensus that this is the standard, but plus minus. We're talking around 20, around 40, around 50. But if you go and see the standard, they say it's 40, it's 30, it's still applicable. But the message here, standing, the pressure usually is higher, sitting is a little bit less, supine is the lowest. This is the message that you get. Vesical pressure وشوفي pressure and vesical, abdominal and detrusor, they are all connected. فwe talk about vesical لأنه highest. الابdominal ينقص منه يطلع الديتروزر. فلما نتكلم على الريستنج أو when we start لأنك أنت بتطالع you will look at the highest اللي هو الفيزايكل. و after that you'll check the abdomen. not the لأن الديتروزر كم مرة قلنا what's the number؟ قلنا 0 plus minus 5 minus 5 10 it's all acceptable. But don't make vesical 50 abdominal 10 then detrusor will be 40. طيب. This is a condensed tracer. It's written here. Filling cystometry, صح? What do you see? Quick. Filling cystometry. First thing I want you to say, there is a good annotation. معلم ومضبط. You have the signs. It's written here, filling cystometry, first desire to void, strong desire to void. I know that you can't read it all, but this is, when you see these words, means the guy who did it is an excellent guy. He wrote everything. Urgency, leak, cough, detrusor of urgency, leak, strong desire. دكتور في المستشفى السلام لما ينزحم يروح يسوي اليوروديناميك. Okay? And he has 4 cases. You know what, I'll do it later. And he will put the tracers. There is no time I can write on the system. I'll do it later. He come at the end of the day. He has 3 or 4 reports. He doesn't know which is which. Was he the one that he had cough, or was that one? Or is this cough? Is that? You end up by guessing. He's the same interpreter. He's the same who did the test. That's why it has to be done on a spot. Don't say, I will wait and do it tomorrow. Not tomorrow, I will do it after 1 hour. And I have big fights with my colleagues, my junior, my specialist and resident when they do this. دكتور احنا عندنا sorry, finish it, do it on the spot, otherwise don't do the test. Give the patient, and you asked me how many patients do you do per day. I told you 4 to 5, each we have 2 urodynamic rooms. We can do 10, by the way. But because each patient, I'm giving the staff the time to make sure that they do a really good urodynamic practice, not just do ما يسلقون الفحص وخلاص. We need to do it in the right way. وما نبغى نعيدها. We don't want to repeat that test. Good annotation. You can see here that this is abdominal, this is detrusor, this is vesicle. Here is a detrusor overactivity, and that's again filling. والأهم on all this, the most important that, as I said, this is a good annotation. هنا you have to make sure that trace quality. When you check trace quality, this is the beginning of the interpretation. When you start the test, just make sure that the quality is good. The scale for the pressure here is good. The scale for the time is good. Do you want to condense it? Do you want to expand it? You can do it in the system. Just make sure that you do it on a spot, live, because you cannot change it later. So you have to do the things. Of course, you can condense or the paper itself, but I mean during the test in order to check the results. Trace quality, resting pressure, filling systometry. ايش هذا؟ فيزايكل كم هذا؟ كم؟ 60 صح؟ high, low, normal؟ resting pressure هنا it's high. لما نتكلم when we spoke about good quality, we should not start with the pressure of this 60. So this is something that you have to fix it. Sometimes, you know what's the reason sometimes? Thank you so much. It's when we say that we have to move the transducer up and down. It's just probably the transducer. Switch, drop it, and you'll get the results well done. So again, this is a quality tracing of your urodynamic. Good trace annotation, as we said. It's important to have annotation of your tracers to make sure that you or the one next after you who will do the reporting can read and interpret the result correctly. Normal fluctuation في الابدومينال راح تشوفوا كثير من الاوقات من الابدومينال يا يكون الواحد يتكلم قرقره في البطن ولا whatever, but it's normal. This is just acceptable within the range as long as you see here that the detrusor pressure, the detrusor tracers is good. Our quality and safety officer, cuff, 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 and it's all here is usually it says 0. طبعا you will see something here. Here it's cuff induced detrusor overactivity, but here يجي زي ال ECG up and down. So it's again, even if it's not 100% 0, but up and down will zero it. So this is normal. As long as this one here and there, they are similar. So this is good cuff testing. Artifacts. يلا ايش نشوف هنا؟ Guess. By the way, can we change the color of those tracers? And a detrusor, I always keep it yellow for urine color. You can change the color the way you want. When? هنا. طيب ممتاز. شو بعد؟ شوف هذا هنا، صح؟ صح؟ هنا resting pressure more than 10. You remember we mentioned that we have to have resting pressure that is more or less plus minus 10. ما يكون be a big difference, otherwise you'll have a trouser. هنا it's high, this is low, so the difference you are getting a trouser pressure that is high to start with. This is 1. فالبيدت وصلت more than 20 وهو اصلا up to 20 is normal. فكيف انت بادي ب 20 لا تجي تقول لي طيب انا بحسب ال 20 على انها صفر، مو بهالشكل. This report will be taken to Massimo in Italy. He will go and read it. He doesn't know your situation during the test. He will look at it, oh, this trouser pressure 20. It became 60, it's high. So don't expect that everybody will understand that you're doing your urodynamic in the wrong way and I can interpret it. It's not only you. You are giving this message to others. And I am a center of excellence. I receive a lot of patients. They send the patient to me just for urodynamic. They want a report from me, not the treatment. راح يزعلوا إذا أنا عالجت المريض. هو ما يبغى يعالج المريض. They want me to write a report, give them the assessment and the recommendation, and send it to them. طبعا sometimes we steal patients from them, but this is the way. They want us to read it and send it to them. Position change. When you see this, remember when we say the خلاص من تشوف all of a sudden there is a rise or a drop, all of a sudden, it's not the bladder. The bladder will not change this sharp. باقي واحدة.
Or you can change the position, but you have to adjust the height of the...
Exactly. Once the position is changed, you have two options. What is it? He said you want to change the height. لا هو change the position. This change the transducer. What else? Annotation. Annotation. Write down here. Changed position. Write it down so I can read it and understand that this is a changed position. Don't let me speculate. Don't say, oh, they changed the position. شوفوا هذه. Once you see sharp, very sharp, afia, immediately 99.99% it's related to the device zeroing either catheter or transducer, or the catheter is completely out. فit's related to the most if it is out all the time, it's all the way, then you will find a big drop. If it is this level, this means I had a problem, I wanted to fix it, I zero it. I make a zeroing, and it came to this level. So re-zeroed. This is what we learn. By the way, this is from the same device from the previous one. The difference is I did this without annotation. The other colleague did it with annotation. So this is again just for us to understand what are the things. We started first with the first recommendation. Make sure that you do annotation. And we'll go with the writing a report and interpretation. Here, after fixing everything, تحرك المريض, moved up and down, we change, we zero the levels. Now it's becoming normal, and this is normal tracers. Quality control. Again, every few slides will give you a message for quality control for the interpretation. Eyeball the trace. Initial impression counts. بمعنى مثل ما قلنا على Euroflow. كذا look at the trace, take a quick look. See everything. This is initial. You can assess the issue if there are a problem or you can quickly look at it. Let's finish the test, and you find and discover a problem. Then you will have to repeat the test again, which we don't want. Is the trace annotated? Are urinary events captured? First, desire, urgency, leakage, position change, as we said, everything, name it. Anything that happens during the sitting, this is what we call it annotation. Regular cuff, consider alternative to cuffing, straining or valsalva, quality of fine movement of trace artifacts. يعني اللي قلنا موضوع القهقه او الضحك او الكلام او شيء, we consider it إنه حتى we can write it down that patient moves, patient talk or something like that. So cuff, it has to be controlled. Quality control, annotation, investigator may not be the trace interpreter or treating doctor. This is what we're saying. Don't consider that the others will see the tracers or the report from your eyes. Everybody has his own eyes. The one who's doing the test on spot has more knowledge and data that can write and annotate. The others, unfortunately, they will receive the report or the tracers blindly. Good practice, an accurate record of event during the investigation. سمعت يا دكتور؟ لا يسحبك الدكتور ويقول لك تعال عندنا منظار ولا شيء، قل له أخلص الأول. Unfortunately, it's a trend sometimes, and people they believe we can do it later. This is not a good aerodynamic bracket. طبعا by the way أنا يعني بس أنت الوحيد اللي تشتغل aerodynamic عشان كذا. Describing what you see, the analysis. What are the BAB, BVAS, BDIT at the beginning of the filling cystometry? What are the BAB at the filling at the end of the filling of the cystometry? And what are the abdomen vesicle detrusor during voiding cystometry? This is, you have to look at it. طبعا, again, it's in the system and it's computerized, it counts, but you have to record it in the notes when you come up with, because this will help you with the diagnosis later on. This is just an example, some annotation here, and here is showing you pressure, obstructed, and what else? كم وصل البريشر هنا detrusor? 71, which is high. Resting pressure, again 24, 23, it's 0. This is acceptable. Excellent. 39, 39, 32, this is 7. طيب. What is this? Fall and pressure. وبعدين بدأ في voiding. فstarted the voiding phase. This is the detrusor to reach to, no, voiding. This is voiding now. So here is the Euroflow started, and this is they emptied around, it's not written here, but it's reached to 86, has an element of obstruction. Here, Qmax 17 ml per second, BDIT 77 centimeter, B abdominal 50, vesical 127, for this is obstructed. True? واضح? This is the one. 77 is obstructed. Well, again, if you go into the calculation formula, do it with the Abrams-Griffith, which will be automatic again. You will get it, will come up with obstruction. This is when we say eyeballing quickly, like a Euroflow. When I look at it this way, I see this number, I don't need to look much. And I can see and know here, there is a compliance is good. I don't need to measure it. Compliance is good. This is cuff. It's good. So test is valid, no problem. Here we have starting to have some use of abdominal, then started to have allow voiding. This is reached to 77, start voiding. The flow is looked like more of bell shape, which is acceptable, but 17 ml with high pressure of 77. So this is most likely, that's a male with an obstruction. For good interpretation, we have to consider bladder compliance, bladder volume. As we said, you remember I gave you the example? 400 ml over 10, 40. So consider 40 ml for each one. 40 is normal, abnormal, compliance. Compliance. Normal or abnormal? ها؟ abnormal ليش؟ compliance يا رجل أثار الغداء واضح بدأت تشتغل. lunch effect. What compliance number we said when we say it's impaired compliance? لا 40 normal. What is compliance? Difference in على difference in pressure. You don't need to memorize it. Make it simple. You don't need to memorize what is the volume. What is the volume of the bladder? Normal bladder volume. Any normal. 300, 400, 500, right? 400. Pressure detroser normal. Normal detroser pressure في الفلين. What is it? ما في زيرو يكون بلس ماينس صح؟ قلنا 5 10 abnormal. قلنا احنا مساحة 20. After that it will be 10. 400 over 10 كم؟ 40. So it's normal. 20 maximum. 400 over 20, 20. Again, acceptable. We said 10 compliance is impaired for definite. 10 to 20 is equivocal, borderline. More than 20 is considered normal. 40, 50 is all considered normal. 10 and below, impaired compliance. What are the significance of 10? Increased risk of what? Upper tract damages. So if it is 10 or less, there is high risk of upper tract deterioration. So voiding times, flow pattern, shape, residual volume, this is all what we mentioned in the year of law when we say we have to do a quick view and look at it. Issues and artifacts, measurement artifacts, air bubbles in transducers, kinked tubing, incorrect placement, migration of pressure catheters. Catheter may prevent leakage. يعني, all these are artifacts that you have to take it in consideration in order to make sure how can I correct. It's not just, you know what, do zero. Zero. Plus the button and do zero. No, I have to check. And we will reach up where are the troubleshootings, where are the causes. But this is just an example. I'll come to the other one. Infusion rate artifact, rapid filling, it might cause some problems, so you have to reduce it. Patient-related issue and cooperative, outlet incompetence, or vesicular reflux. And the reflux will reduce the pressure. It will push all the fluid there. Irritating substance like catheter or fluid media, temperature of the fluid or the pH of the fluid itself. Developing a systemic approach, key point. Consider normal trace characteristic when you are interpreting a tracer, which means understand your normal in order to do the interpretation. You don't know the normal, please give it to somebody to do the interpretation. You are not the right person to do it. You have to know your normal first, then do the interpretation. Maintaining good trace quality, annotation cuff. بمعنى رئيس الquality, the head of it, your safety officer has to be there all the time. Make sure that, don't forget, oh, I did cuff at the beginning of the test. No, you have to do it every minute. You have to do it every minute and ask it. Oh, by the way, the devices usually will give you a message. Ask the patient to cuff, some devices. Ask the patient to cuff if you forget. No normal volumes, range, use of nomograms is helpful to assist the detroser function. اللي قلناها مساعد nomograms. ال A gravis والbladder contractility index obstructive bladder outlet obstruction index, all of these, it's helpful for you to assess, to make sure that your provisional diagnosis or urodynamic diagnosis is correct. Developing pattern recognition skills, only when you can identify normal can you begin to identify abnormal. 1, 2, 3, حتى الفورth I will consider it. Message: know your normal first, then work on the abnormal. Troubleshooting. Good. One time. Troubleshooting. You have to be systematic. طبعا this is not something new, not only exclusive for urodynamic. If you are systematic in anything you are approaching, you will have a good garbage in, garbage out. If you are systematic, you will be systematic in your output, and you will get also a good result. You have to define the problem. Gather the information. Don't get panic. What's the problem? I have problem with that tracers. And by the way, this is not a joke. I'm telling you, the easiest thing people will do once they see any problem without even thinking, not a bubble, not catheter move, zero. And this is the worst thing they do to their test. They think the easy way to make tracers flat, to make zero. Easy, it will be zero. But come and find what findings you can get and do the assessment and diagnosis and treatment according to that. Define the cause. Create options. 1, 2, 3. These are the cause. We already did this test earlier. Either we have to adjust the transducer, either we have to do zero, or we have to, what did we say else? مساء لما كنا قلنا الترانزستور تتحرك. Do annotation. تسجل ان patient move, and we register that. Sort it out. Make a decision. خلاص, you are the surgeon. You make the decision. Think logically, critical thinking. By the way, I have to give credit. These are a collective of almost, I think I did total of 300 plus slides. There are some of those slides from my resident, and some of those slides from my seniors or friends who I got probably 2 or 3 slides from here and there. But this is the way I felt this is the way to create. I created all the slides, but there are some data that you gathered. There are some data from the books. There are some data, as I said, just written from the practice. But there are some slides, I have to give the credits again to those who really brought some nice slides that I have to put them in my presentation. Isolate the source of the problem. Remember, it is usually one of the 5 options. مشكلة ما راح تجي من, although apart from طبعا the electrical problem that we have with regency here, but it's five reasons. It's either the software itself, there's a problem with the software, or hardware itself, the machine, the computer, the device, or the disposables, catheter, kinked, air, patient himself, or the operator, you have a problem. So it won't go outside those reasons. And if when you say think logically, this is what we mean. You have to think, what is the reason? Is it related to software? Is it related to hardware? Software is good. Okay, hardware is good. Disposables, nothing is problem with the patient position, everything is good. Okay, I have to look at problem. Probably I did something wrong. This is the meaning of logical thinking in order to get out of your problem. Again, remember that vital during the test means quality control during the test, not after. When we say quality control, خلال الفحص, while doing the test, I have to do the cuff, I have to make sure that I do the annotation. This is quality control during the test, not after. Difficult to correct for poor tracers retrospectively. إذا فات الفوت خلاص. إذا التريسرز فيها issues, the only solutions come and try to explain to the patient, if they don't kill you, that please we need to repeat the test. because we did not do our homework correctly from the first time. Many to reject poor quality tracers. What does this mean? معلش أعطي عليك example ها دكتور. I use you as another example. No, shall I use you as an example? دكتور سوالي ال tracers and the tracers were poor, and he did not get any good annotation. The report I was not convinced. Don't feel shy, and no, I reject it. أخذ التقرير حقك. I don't like it. I cannot rely. I will consider that the patient did not do the test. So don't feel, oh, I cannot repeat the test. You know what? Let me speculate. Let me guess. No, do your guess without doing the urodynamic. So don't use a poor quality tracers. Consider it as if it does not exist. طيب, very quick here. This is fine artifact. Usually, there are no consensus exactly what does fine artifact mean, but usually it's less than 10. Some people, they say 5, but this is considered normal unless during the test there is linked with the findings from the patient. يعني you had this small due to fine artifact, as you talking or something. Everything is okay, خلاص, you write just fine artifact. If the patient mentioned, because of that time of the artifact, that he had something, I feel pain, I feel urgency, even if there is nothing shown. No, you have to link it. If the patient does not complain, that's it, خلاص, this is artifact, so ignore it. What? That's what I'm saying. Sometimes it's abdominal, so you have to consider, if there is nothing to connect with the patient, forget about it. If the patient mentioned while having this artifact that he is complaining, it could be something that you can link with his symptoms. Then you got me to another good data, and you have to record this. How many patients with overactive bladder symptoms will have a detrosor overactivity when you do aerodynamic? Percentage. You have patient with an overactive bladder symptoms. You go and you did a urodynamic. How many of those will get a positive urodynamic result? 50%. 50% of those patients will have positive, 50% negative. They are symptomatic. طيب, let me help you with writing the diagnosis also. معلش هذا في reporting بس. Sometimes I say, this patient is overactive bladder. Please consider. ما في أوبيجايني هنا؟ ما في, مش الدكتورة موجودة. You remember أوبيجايني we learn to do B3 plus 2 graphida. You remember? This is an equation everybody knows, right? Dental people, they have an equation. If the dentist read it, he knows where is the tooth. Same thing for aerodynamic. Why don't we create our own? Like if you see in my notes right now, if I write overactive bladder, patient with overactive bladder, what does this mean? What's the message I'm giving you? لا. This is what we taught our team, and they know that. Once they see overactive bladder, this means this patient did not have urodynamic. This is because overactive is not a urodynamic diagnosis. It's overactive bladder. Patient has an overactive bladder symptoms, urgency, frequency. Like once I did a urodynamic, and there is a detrosor overactivity. So I will say this is a patient of detrosor overactivity, because this patient has, once I see detrosor overactivity, some people will take it lightly, will say DOE. DOE is a urodynamic diagnosis. If you did not do urodynamic, don't try DOE. The other thing, if I did a urodynamic, and there is no detrosor overactivity, and he has overactive bladder, what shall I write? Overactive? طيب أنا قلت overactive means I did not do a urodynamic. Urgency, frequency, syndrome. When you see in my notes, urgency, frequency, syndrome, automatically it comes to your mind, oh, okay, this is a patient of overactive bladder. Dr. Riyad did a urodynamic for him. They did not find the detrosor overactivity, so that's why he is an urgency, frequency, syndrome. Full stop. Diagnosis واضح ومعروف. One sentence, you know all. That's why you have to create the system and work on it. Cuff, cuff, all these are, what did they do? Okay. Try to. This is the normal tracers. This one, remember always one thing. Again, any of those, when you have it in the exam, just make sure you talk about annotation and ask if it is filling or voiding. Even if I'm bringing you, you will find some slides now that are poor. We're just heading on, just show you how does it show in the urodynamic. But in exams, always make sure that you stress on that point. Does this happen when you knock the pad? The catheters? When you knock it, you will have this movement. Again, how can you tell? You have to do the annotation. You have to write it down. So for me to know. Normal tracers, here I showed you. This is a small detrusor overactivity. Here. Huh? Again, let's go quick and show. What is this? This is this abdominal, this one, detrusor. لا أنا الحين طالع ما في data. We're just a spot. You need to, what is this here and what is this here? Thank you. Some artifacts due to talking or, and this one? Cuff. This is normal. شوف اتحركت الدتروزر. ها؟ اتحركت مقبولة؟ Why? Exactly. If you see this, it's like the ECG changes. This is normal, so it's subtraction. Down, up, subtracted. So some machines will give it 0. Some machines, they have to bring it down and up, and subtracted will be here and there. It will be more or less this normal. This one, physical, abdominal, and here, what is it? We don't have, in the practice, no annotation. We know it's filling or voiding, but if you consider there is no voiding here, and there is no note, and there is no flow, this is detrusor overactivity if it is in the filling. In the past, they used to say if it is less than 10, it's not considered detrusor overactivity. Not anymore. Even if it is 5, and there is sign, and especially if there is patient symptoms, you will consider as detrusor overactivity. This one. Oh, this is the abdominal. طيب, what else? طيب. What are the dilemma here? What is the dilemma here? Huh? What's the dilemma? What's the problem here? Non-proper tracer, so I don't have the data. But let me tell you one thing. Usually after voiding, we don't do cuff testing. After voiding, the test is done usually after voiding. So usually testing for cuffing is during the filling most of the time. But after voiding, the test is almost done. This is one. The second, unlikely you get a leakage like this. Unlikely you get a leak. So most likely this is flow, voiding. Because leak usually like comes into small amount or liquid. This is real full flow. So again, we're not guessing, but your answer to this is just to show you that it could be an obstructed flow, but this is the answer to this tracers. Sorry, we don't have annotation. I don't know if it is filling or voiding. This one. What is this here? You are urgency, which means anytime during filling. فاحنا عرفنا انها filling. This is what? Okay, وفي leakage صح? So we have leakage, there is a detrusor of activity, it's very significant, and this is a cuff test here. Or this one. This is for you, Massimo.
It's a problem with the transducer. It's too high pressure. The shell went too high.
So what is the problem with that one? What did Massimo do when he was helping you?
Probably they flushing the syringe to fill the...
That's why you need to have him all the time there. Again, very unusual. You see changes very harsh and hard like this. This is even beyond the records. Usually there is something, as you said, you did something, either the catheters dropped, transducer problem, or you did a flushing. Here they flushed the vesicle and you got this peak in pressure. So again, you have to annotate it and say.
Same, flushing on the abdomen. The first. E is a flushing abdomen.
What is A? What is A?
Only abdomen.
You remember I mentioned in one of the slides? Cannot go down from the resting phase. So once it's done, خلاص, there is a problem with the transducer. I did flushing. After that, we have this subtraction. Things settled. Here, knocking of the tubes. Just make sure that. After that, we brought our quality engineer, asked him do the test. He did the cuff test. Things are okay. Go ahead, you are safe to go. So this is the way you do. This is the way how to be interactive when you do the testing. We have, I think, 5 minutes. Again, you remember we said if there is sharp drop like this, خلاص, dropped, all of a sudden, big drop like this. The catheter is gone, out. This is cuff. Is it correct?
Yeah, because the vesicle is not responding well, so they flush it.
They flushed. They did cuff. Quality جاي تو check طلعت negative. فوق ما في شيء. صح؟ Which means there's a problem. So what they need to do? They did flushing. They did cuff. Subhanallah. Without cuffing, you cannot live in urodynamic. Yalla, what else? بعد سهم بعد. في النهاية you reach to a good cuff response.
The answer of the cuff is not good, so they flush it.
They did the flush till they get good response. That's why don't underestimate the cuff testing during your, and don't feel that if I do it every minute, this is too much for the patient. This is هذا طريقك إلى الجنة في اليوروديناميك. هذا المخرج الوحيد لك. Flush. Poor cuff response. Check equipment. Zero it correctly. Please don't do zero inside the bladder. Check setting of catheter. Make sure that setting of the catheters are correct. flush catheters, especially طبعا flush, by the way, this is in fluid, not in the air. Air you cannot do flushing. So you have to make sure that the transducer is correct. If there's a problem, you have to change the transducer itself. And this is one of the advantage of the fluid transducer. You do flushing and catheters. That one is, you are tight a little bit. Reference level. Again, remember your reference. Again, when you see this drop, there is a problem. This is not acceptable. B vis and B abdomen should not drop below 0 during filling. Okay, if you get abdominal below 0 or you get a vesicle below 0, it's not possible. It's a collection of pressure, so you cannot get it below 0. I think we can skip this. Good cuff subtraction, as we said. This is straining, and the trouser is 0. Here is abdominal and vesicle. So this is the patient is straining. Flushing pressure line. Always when you see those, this huge, again, it's a flushing. Flushing the pressure lines, often the pressure, and the most important part here, don't do flushing with 1000 cc. It's like 2 ml usually. 2 to 5 ml to flush the line. After flushing, ask the patient to cough, bring your quality control. If okay, continue. If not, repeat the flush. Sometimes several attempts till you succeed. Don't say I did the flushing. No, do flushing till you fix it. The same thing. Drop a rectal abdominal pressure that you mentioned. Rectal line has lost position, fall out, lose connection, or sometimes equipment or transducer failure. Call it equipment disconnected or failure of the transducer itself. What is this? طيب. What is my answer here? شنو؟ Annotation. Thank you. خلاص. It's my right to say. There is no annotation. I don't know what you're talking about. There is nothing. Here, I can speculate again, but there's nothing. So there are some slides that will say, I don't know what's happening. You'll see another slide same. Here, again, there are things that, definitely it's related. As you mentioned that this is a sign, clear sign of a flushing, drop of the catheters. You cannot speculate all the time. So here, you see, remember we said, drop below 0, minus. Loose connector, they connected it, they fixed it, and it worked. Poor subtraction checklist. This is just example. It's like, when you have a reference and it's written, frequently asked questions or frequently asked problem. Air in the system, dampen signal. You will get signal تكون فيها زي الدنبلة كده تصير. This is related to the air itself. Check for loose connection, tabs, lower lock, transducer catheters. This is all in the fluid catheter, not in the airflow. Loss of pressure. لما يكون في loss of pressure when you have this problem. Damage, broken equipment, check transducer, not just the dome cover. Just make sure that the transducer is really, there is no problem with the transducer. Sit up, is fluid filled, is the tubing primed? Sometimes the tubing itself, they have air and it's not primed and does not go. And I had this problem once, I remember. They connected this and it was not entered correctly. And the machine was keep running, but there was no fluid coming in. And we don't know. And then we discovered that the saline was not moving, still there. This takes us back to the one that we showed earlier. معجب فيها جدا. Nice annotation. Nice annotation. You like it when you see everything. Worst annotation ever. Nothing. It's just like kid's drawing, so you cannot tell anything from it. Is it drop? Is it catheters? I don't know. It's everything that nothing is happening, I cannot tell. Troubleshooting, flush catheters, air does not transmit well, so you have to flush. Check DOMS, reference level, re-zero till you get the correct and re-zero the right way, not into the bladder. Start filling up to 50 ml catheter against the bladder wall, which means if the patient starts feeling that he is at 50 ml and the patient is having difficulties or have urgency, make sure that probably it's just against the wall, so the patient is having some sort of sensitivity. Just try to move the catheter. Resite catheter, because of this, change catheter, double lumen, solid state, if you need to change. Troubleshooting, check zero, stop, check, be sure. Contact details for manufacturer. Always make sure that you refer to the manufacturer, although they have a lot of similarities, but there are some companies, they have more specific. Equipment handbook that's available with the, and hopefully with this, you can have a good urodynamic practice. Now, last but not least, before we go into the, we'll try to, inshallah, we'll finish before, so we can get some time for more practical. Writing a urodynamic report. This is the last phase of your urodynamic journey. This form, and sorry to give you a copy of a form that's probably not clear, and again, sorry that I did not cover this, and I will say this, I don't know why I'm not covering it. I created this form in 2008. We as a physicians, very lousy. We don't want to do a lot of paperwork. And in order to convince my team, when I came back from my scholarship, from fellowship, I had a resistance and fight with one of my colleagues. He had a urodynamic report of 5 pages. And I challenged him. I told him, tell me anything in the 5 pages that you have that does not contain in this small 1 page. So in order to make it easy for the one who will write the report, for the one who will read it, for the one when we send the report to outside doctors, I need something small, short, concise, and I need to the point. I don't need 5, 6 pages with all the details. Why is that? So we made this. I divided it into history, including exam here. Of course, at the beginning was the physician, video, non-video, neurogenic or non-neurogenic. It will give you a hint. Initial uroflow to start with. Then a filling, including the 5 C's that we talked about it. And then voiding. Here, where is it? Here, the voiding. This is all the filling. And everything related to the filling is in here. Nothing is missing. Nothing is missing. Nothing. Everything. By the way, this is an old one, huh? This is from 2014. Now it is adopted in our system and it's electronic. Just you fill in if you had drop list. It's made easy. Hopefully, inshallah, I will share with you the electronic form that is with a drop list. Each one here has a drop list. So we'll just try to make it easy for the one who will fill it. Filling, voiding, then EMG, was it done or not done? Write down, video. As I said, we don't do urethral pressure profile, so I did not include it because from long years I don't believe in it, so I don't do it. And here, what is the finding in video? What is your urodynamic diagnosis? What is your treatment plan? Isn't it what we all mentioned in the previous presentations? This is what we need. From the history till the urodynamic findings لحد خطة العمل حقت your treatment plan to the patient himself. Everything. So now when it started to be digitalized, it became more convincing. So it should convey a real information that is accurate, relevant, and important with the diagnosis and the management plan. As a treating physician, I don't need 6 pages details of every single word in the urodynamic. You have this copy that is generated from the system. Attach it for those who are interested to read it. But give me summary of what I really need. And what you really need, and intentionally, by the way, I brought this. And this is when I say, it is 1 page, and I still fight with my team earlier in order to make sure that they fill it. They will come up without filling most of the points here. كيف بدي أسويها لها 5 صفحات? How if I do it 5 pages? I will not fill it. 1 page and still we struggle to fill it. Hope طبعا things change right now. So advantage of good reporting, referring doctor can decide on a management. Other doctors can decide on management. Yani if I'm the referring, or if I send it to other doctor, they can decide on the management. Medical legally, you have something, a document that is medical legally documenting everything. Used in teaching, to bring it here and discuss it with you. Used in research, and we are poor, unfortunately, in research, but we're talking about almost 400 urodynamic, 500 a year. If we talked about 15 years of urodynamic study, just in my hospital, we're talking about more than 8,000 urodynamic. You know how much data we can get from this urodynamic? But we are getting 1 or 2 studies a year, and يعني نعمل فيها حفلة. While we should get really a good number that we can get a lot of data. And compare with the future urodynamic. When I do urodynamic and there is a good reporting, if I do this for a patient with a neurological disease, I'll check the urodynamic and see what's the difference. Especially like nowadays when we do a Botox or something. What to include? Again, not to go into the details, but as I said, history and examination, we have to write if there are any parts of the labs. This is the standard. Frequency volume chart if it is there, free void, urethral pressure profile, EMG, filling cystometry, video, comment on that free flow if it is normal or not. Urethral pressure profile, as I said, I don't do it, but I cannot deny those who are doing it to put it or not. Filling, voiding, video, and put your impression and put a plan and follow-up arrangement if patient is with you or with any other doctor. What is this? FVC. Huh? Frequency. It's exactly. Frequency volume chart. Frequency volume chart, we as Arabic, most of us, we really don't get a lot of attention to it. Although it's really important and we like it. I will show you one that also I did it in Arabic. It helps a lot. It gives you a real picture of what is the function of the bladder and how is this patient. Sometimes the patient will come to you, I tell you, hi doctor, and I void 30 times a day. You bring you the voiding daily, it's like 6 times. Ashrab, okay, show me how much you drink. Write it down. They will write it down, nothing. I drink 3 liters. Then it's just like 1 in the morning, 1 in the evening, and that's it. Voiding dairy frequency volume chart is really important. And again, frequency volume chart, there are a lot of details. Hopefully I put some, here. This is the detail, this is the one that you have to use and do, and this is the standard one. Again, I tailored one in Arabic. استشمل في التخصصي تسجيل يومي لنقط بول وشرب السوائل. And I always tell the patient what to fill, not to fill, because I tailor it. I don't want them to fill everything. If patient doesn't have stress incontinence, what I do, I put my pen, I tell, you know what, حفاض X, سلس X, هل السلم X. You don't need to bother yourself. He will feel comfortable. Okay, here, مثل اللي في الواجب in the school, they say, from page 1 to 10, don't read it. From 10 to 20, complete. They will feel happy. So you tell him, don't do this, don't do this. I want you to fill this and that and that. That's it. Enough? Okay, no problem. I want you to do it in 3 days. Simple, voiding, diary, solve the issue. I don't need to stick to a very complicated voiding theory as long as it does. And by the way, I tried 6 years ago to do a validation of the voiding theory, but again, because we're a little bit يعني what do you call it؟ شو ممكن نسميها؟ قاعد اختار كلمة غير الكسالة. سنها ما في إلا هالكلمة هذه يعني very poor, and at least this is one very poor in really encouraging everybody else to do a research. So that's why I do some chapters, but during the study you try to ask all the residents to participate. Few of them will participate, but I think we have a lot of data to share with everyone else. Free flow, QMax, تكلمنا فيها flow pattern, BVR, compared with the normal voiding pattern. Filling, again, this is a discussion that we had in the morning, but here I'm bringing it to you to show you this is what you need to report, because now you are reporting, you are writing it. So you have to make sure that to include detrusor function, stable or detrusor overactivity. Yani already you have seen it, but now you have to report it. Effect of provocation, if there is a provocation, water, movement, if there is cold water or whatever, if there is leakage, compliance is good or not, bladder capacity, reproducing of symptoms, voiding, QMax, voiding pattern, men. This is an explanation of the form that I showed you. Bladder outlet obstruction, index, bladder contractility index, women, normal or underactive or acontractile, or if there is after contraction, what's there, and if there is a post-void residual, what is the post-void residual? Video Urodynamic. You remember I told you the 5? There are 9, I think here. 9, it's the same as the 5, but divided. There is nothing extra. It's the same. Bladder shape, trabeculation, diverticuli, pelvic floor, bladder neck, vesicular reflex, stricture and in the urethra, fistula, or post-void residual. Diagnosis, write your urodynamic diagnosis. It has to be a urodynamic diagnosis. ومنين تاخذوا urodynamic diagnosis؟ اللي وريتكم اياها الصفحة السلايد اللي I repeated 1,000 times. Urodynamic diagnosis. It has to be from this slide. Don't write other urodynamic diagnosis apart from the one that is in a slide. Relevant findings, test the difficulties. Yani, if there are relevant findings during the test, you have to mention it and write it in the report. Or if there are test difficulties or difficulties in the interpretation, either you say test difficulties, patient position was difficult, obese, or they have joint, or they have this issue or that issue, or if it is child, the active, or if there is difficulties in interpretation for a reason. Let's say the device was not working good, there is a problem with the blah, blah, blah. Just write it down just to support and document if it is good or bad. Suggest a management plan. You have to suggest a management plan. Even if he is not your patient. I will write a management plan to the physician who referred it to me, and it's up to him. Prophylactic antibiotic, I think we spoke about it, and we said for those patients, for us we use prophylactic all the time, but for others they use it only for complicated cases or with a patient of high risk, infection, neurological diseases, or if there are patients who are in pediatric age. Follow-up instruction, write down an instruction for the patient's use, اللي هو when to come, what to do, write down the instruction, and usually we give them a page or a sheet that is contain all the instruction. Again, this is another example, and it took us really long time to convince the team to fill it in the right way, and things changed when we did it in a digital. So with the new system, when it was digitalized, it make things different. But I'm just stressing here on one thing, just to show you that one sheet can contain everything, and you can do it, and you don't need anything else. Probably you will miss some part, but this is I would say minimum it will cover, and for me, 100% of what I need. But say 90% coverage, that's fine. Case discussion. Now we're done. Now this is, in the coming 30 minutes, I will leave, or 30 or 1 hour, it's up to you. I have some cases. We already discussed many tracers. The case is the same. We're not talking about a real case scenario. We're talking about urodynamic cases. But this is, again, just to show you some other slides or some other tracers that familiarize yourself with urodynamic tracers from different machines. Hopefully we can get some tracers from your machine too. You can add it. إيش هذا? Again, let's forget about just tell me that there is a problem with the annotation, or what can you see? And I brought this specifically for one reason.
So we have not to take care about the annotation just...
No, say annotation, but as I said, this is a snap or capture to show something, bas. The others, that's why I said it's just like extra. But again, always, especially in exams, don't get fooled by not mentioning the annotation or if this is filling or voiding. This is always. خليها كده standard, like بسم الله الرحمن الرحيم. Is this, huh? No, I mean, probably it's not enough for you to know what's going on. But here there are some annotations. But I'm saying comment on that whenever you want. Here, specifically, I brought it for something. Can you see something here? Excellent. من اللي انت قلتي AMG. إذا لاحظتي ما نجيب AMG كثير صح? We don't have it. I brought it. This is an AMG here. It's done. What is showing? Huh? See here, you have the trouser pressure. With it, all the time, there is an AMG activity. What does this mean? Feed the trouser overactivity, and you have DSD. DSD, that's there all the time. Again, AMG, look at it. And here, relatively, there is a good annotation. First sensation is there, MCC, Qmax is there, Beta Qmax 24, voided volume 585. What is it? Again, see the voided volume, flow rate, and you have the AMG activity is very, exactly, during the flow. Exactly. So this is the trouser sphincter, the synergia. So again, طبعا they added here hyposensitive لأن they said the maximum systematic capacity 1,200. Again, as I said, never do this. You don't need to fill the bladder to 1,200. You can do it. So there is nothing to justify filling a bladder to 1,200 during a urodynamic study. This one. Why? Why? When do you consider underactivity? When do you consider that trouser is having underactivity? First of all, let me know, during filling or voiding? اي ترى بجيب عصا الحين خلاص اذا شوفوا obstruction, you cannot check it during filling. Trouser underactivity, you cannot check it during filling. Don't ever make this mistake لا في exam ولا مع patient. Never do it. This is to be checked in voiding. وأجين أنا طولت ما جات هذه السلايد غريبة. السلايد هذا حفظوه. احفظوا هذا السلايد كده by heart. Where to check, where to get the diagnosis. As I said, you can say this has a detrusor overactivity with detrusor, with acontractile bladder. He has detrusor overactivity with acontractile. So this slide, these are the diagnoses. يعني imagine instead of reading 1,000 books, you have only 8 diagnoses that you need to play with it, and you come up with a diagnosis of your urodynamic. You don't need a lot. You have طبعا في حاجات extra, but this is what I'm saying, the urodynamic diagnosis. لأن you can write in the finding, there is a diverticulum, there is a bladder outlet obstruction by urodynamic, by video, there is evidence of 1, 2, 3. We're talking about the urodynamic diagnosis itself. Yeah. The trousers under activity. Yeah. Exactly. So this is a detrusor under activity, and usually I consider either a contractility. Of course, it's like usually 0. In our assessment, usually if it did not reach to a 5 centimeter water, we'll consider it as a contractile. حتى لو وصلت إلى 5. Others, they will consider any activity as under activity. Then it has to be 0. Sometimes we from our side, we take it anything above 5. Less than 20, I consider it underactive. So less than 20 is underactive. I think this is repeated. Just again, this is here. It's all good annotation. They fix the flushing, the cuff. And this is, I think this is from our machine, yeah. And here, you see, this is obstructed. Here the flow start. See the pressure here is 208, and the flow here is almost 10. 7. 7. So it's obstructed. Again, this is quick just to show. Again, where the connection of the, there are some devices that they connect the video with the machine of the aerodynamic. Do you have this connectivity? Excellent. So you can have the video option, so it will be easy to add it in the report to capture the picture. Here, just to show that if you hear that distal sphincter does not open. Again, it's a picture of the synergia. High pressure, voiding problem. I don't think we need to go into all of this. This is again one of the advantage of the video. Just that will give you if there's a reflux, so important to capture it. This is the same patient. هذا اللي كنت أقول لكم. This is what I was telling you. There are some from books, some slides that are not clear, but this is a collection that sometimes will help when we discuss the cases. And there are many cases that they discuss here just to show. For what is there here? يعني, لا, give me. This is. I'll just give you. This is filling. This is the trouser. Just give me one finding. لا. Without numbers, just tell me. Once you see this shooting up like this, impair compliance. المفروض البلادر. You remember we said what is the phases of the cystometry? We will have slight increase, بعدين straight, بعدين jump at the end. This is no. This one is coming up, coming up, coming up, coming up, coming up, reaching to here 64. يلا ممتاز. كم الفوليوم وصل؟ الفوليوم وصل 500. زين؟ 500 وصل من هنا إلى هنا 61. 500 تقسيم 60. طلعيها كم تطلع؟ امبيرد ولا نورمال؟ كم النورمال قلنا؟ أقل من 10 قلنا 10 إلى 20 equivocal above 20 above 20 normal above 20 normal هذا severely impaired. Did I read the numbers? Again, this is when we say eyeball the tracers يعني طالع سريع وشوف. Then you confirm. الحين احنا شيكناها ما قاعد يقول خلاص اكتب الديagnosis. You have to write impaired compliance it's like this. But the moment we looked at it لا هذه impaired. Let me check again, see the numbers. Poor detrosor compliance. هلا يبا. أرجع. إيه. Excellent. 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 What is when you can say detrosor overactivity?
لا يكون absent الدروس increase أو بس increase بس ما في abdomen أو
والcompliance
صح يصير sudden increase
والcompliance يكون no compliance
لا في يعني normal compliance
الabdomen should be normal all the time. Good? We have vesicle and we have detrosor. The difference between compliance, impaired compliance pattern and detrosor overactivity, the impaired compliance, it will be continuous. This is one. You will not get a detrosor overactivity like this. Even, لأن شوفي, it's about physics. This is an increase of pressure. Detrosor overactivity means that contraction. الكونتراكشن الفاست twitch لأن هذه smooth muscle. الفاست twitch has seconds limitation. It will be exhausted, so it will contract either quick or take few seconds and it stop and come back again and come back again. So we call this phasic detrosor overactivity. It cannot be one detrosor overactivity. This is one. This is a second thing, again in practice, for compliance. When we say compliance is impaired here, this is the compliance here. Again, you might have normal compliance. At the end, خلاص يجيك المريض at the end of the procedure, like when he reached 300, start to have the urgency, you start to have pain, and the compliance started to increase here.
I think this is normal.
No. Level to a level. You have to measure it. This is normal. This is number phase كم fulfilling. This is phase 3, right? When I mentioned it in the slide, this is phase 3 في السيستومتر. هنا قلنا بزيادة بسيطة ويرتفع هنا. When it reached this, in order to measure if this is normal or abnormal, this is when we say when the check of the compliance, you have to make sure that you choose the representative dots during from the tracers, which means if there is a symptoms of the patient has leaked here before they start voiding, increase impaired compliance, reach to a level here, let's say here it was 10 and here it reached to 70, 60. Shall I measure difference 60 صح between 70 و 10 60. I divide the volume over pressure. Shall I divide the volume which is 500? No. Exactly the same dots here, right? Yes. So increase from 10 to 70. Here we had 50 ml. So 50 ml over 50, مو 60. It is 50 or 51. Severely impaired compliance. Again, this will increase the risk even. So what you will do, what you will advise this patient, that's why you need to tailor it. What you will tell your patient? He is completely normal. أعطيني one piece of advice. You tell this patient, without going into details of medication, one piece of advice. طيب كلنا we need to relax. What else?
They have to go with the first feeling.
Excellent. موديفايد شويه، في لها اسم في ها؟ لا، ما فيرست ديزاير، هذه كلها في اليوروديناميك، المريض ما يفهمها. Excellent. What does this mean? What is it in our book? Thank you. Time voiding. Timed voiding. You have to tell the patient, you know, understand now that into 300 ml he's doing excellent. من يوصل ال 300 يبدأ يخرب. You have to ask him to do a time voiding. Don't spend more than 2 hours. You need to go to the bathroom. If you drink a lot of fluid, you need to go earlier. Don't reach to that level. Average that consumption of or urine production from 20 to 50 ml per hour. If it'll say 100 ml if he is a lot of drinker. So if you say above 300, okay, not to exceed 3 hours by any means. So it's called timed voiding. And I always connect it to prayer here. I ask them if he is praying either 5 times a day, 3 times a day, I connect the days, the rest of the time between. إذا أنت تصلي في الفترة فجر, ظهر, المغرب, in between and before sleep, you have to do it. Try to reach 6. مغرب, ظهر, عصر, مغرب, عفوا, فجر, ظهر, مغرب, عصر, عفوا, عصر, مغرب, عشاء, 5 مرات كذا. أقول له before you sleep and you break between fajr and ظهر. So it will be like 6, 7 times. You try to divide the time and tell them, guide them. Because some of them, they think, no, I'll just go before prayer, and that's it. But time voiding is important. I think these are all repeated. Let me, again, this is involuntary contraction. This is the picture of last year. Do you know any of those? هذا أنت صح؟ والدكتور وينك موجود؟ ما صور الدكتور. ها؟ وينك؟ هنا. أنت هنا وهذا أنت هنا صح؟ ما شاء الله ملتزمين، تأخذون شهادة دبل شهادة. مريم في إيرلندا. دكتورة سارة was with me last year. I think she attending the conference. But unfortunately, she was not with us here. Again, thank you so much. I hope you learned something from the course, and I hope that it was helpful, and I need to hear, you can operate the device?
I want to give just some suggestion when you have, because I see as a technician, when the doctor called me to say we have a problem. Normally you show a picture where you say the problem can be software, hardware. I will say I make a reverse. Normally the problem is the procedure, so the problem as you are doing in this moment. Then can be a problem of the disposable. Then can be a problem of the hardware, and the last is...
I got your point. By the way, thanks for mentioning this. By the way, when I put the 5 reasons, they are not in order.
Yeah.
They're not in order. It's just like the software, hardware, disposables, patients, or physician. It's not like the physician is the least. It could be the highest. It's not in order. This is just to stress on that. But these are the categories of the reasons behind any defect. طبعا this is not the last slide. The last slide, any guess? I'll have it. This is just a summary. طبعا, I think by the end of this, you understand the message. When we say urodynamics is the gold standard for diagnosing patients with lower tract symptoms, it defines and document voiding pathophysiology that causing the symptoms, and it's the only objective study. It's the only functional study that we have in our hand as a tool to assist patients with a voiding dysfunction. And it has an importance in elucidating the voiding dysfunction, especially in neurological disease. We can potentially give an objective measures, this is important, in pre-op for a post-op outcome. I did not want to put this at the initial introduction because this is a message that you have to take it with you at the end of the course. That's why urodynamic is really important. And we have really to utilize the urodynamic. Sometimes everybody feels that, you know what, easier. I'll do it without the urodynamic. I know this and that. Again, as I said, if it is against the guidelines, you don't want to go. There's nothing against the guideline. The guideline will not say that it's mandatory. They will say it's an optional. I encourage you, if you have it, you can do it, go with it, even if it's an optional, because it's not contraindicated. So it is an extra tool that you will use it to help. Thank you so much. Unfortunately, about the slide, يعطيكم العافية. Again, it seems that it disappeared. The slide was to be the last. اللي هو I don't know why it's not showing. يعطيكم العافية جميعا. Thank you so much. الله يعطيكم العافية. Sure, I'll send it to you. طبعا you saw يعني هو 300 تقريبا وشوي. لا I'll give you if you have, this is my listen, this is my email, and this is my Twitter, and I think I have scan this. شوفي ليش يطلع فيه بس بتأكد شو الرقم والإيميل اللي فيه لأن I forgot about it. لا قبل ما خلينا نشوف. لا هذا مال لا
هذا اللي اي سكان طلع لي ايميل.
ايش فيه رقم التليفون؟
رقم 056
واللي تحت نشوف. هذا ما ها لا you know what هذا ايش محطوطه اتش ولا ار ليش مو واضحين؟
هذا ار اي رياض.
at hotmail. اوكي بس don't use the MOH email. هذا كرتي الرسمي. Don't use the MOH email. Use the hotmail. There is a telephone number.
Yes.
Use the WhatsApp. في طلع. Share it. Try to. Save it and add. And definitely, if you need any help, if you have any patients that you need some consults or questions. ما فتحت؟ ها؟ هذه ما جيت الشرقية شكلك من زمان. ما لا حطيت لكم الصورة في الأول. لا وهذا اشتغل فيه ما جيتكم خلاص كانت هنا. تعرفون مركز إثراء؟ أي هذا مدينة الملك عبد العزيز هذا تبع رامكو. هذا مركز إثراء الثقافي one of the best centers in Eastern Province where they have all the الحفلات الآن الحفلات دائما الراقية تكون يعني مو يعني سواء كانت مسرحيات أو حفلات غنائية أوبرا يجيبوها في هذا المكان. المسرح خرافي طبعا في اكتيفيتيز شفتوا زي اللي شو اسمه عندكم هنا الساينس سنتر او اللي على ها ايه لا الساينس سنترز اللي حق الاطفال ما عندنا زيه في الشرقيه اسمه برضو المركز في نفس الشيء انا زرته مع الولد من نفس الشيء هنا الان هذا على هايست سكيل ريلي هاي سكيل بس انا اي لايك اباوت ات اتس كولد مركز الاثراء الثقافي. دائما يجيبوا الحفلات تكون جدا عاليه على مستوى عالي يجيبونها فيها. فاني هاو اتس بيكم ون اوف ذا معالم حقت مركز اثراء. مركز إثراء. هو الصورة الثانية لأن أصلي أنا من الأحساء حساوي. this is from الأحساء. This is from منطقة القطيف تاروت. هذه أشجار المانجروف. إيه يعني بس لك على شيء على الجو، لا يغرش الصورة بس. فهذه في منطقة اسمها I don't know if you're familiar with القطيف، في منطقة اسمها تاروت، جزء من تاروت مرتبط بسيهات. في أشجار من أكبر أشجار يعني في جيزان في المملكة، وفي المنطقة هذه فيها الأشجار المانجروف، ففيها حتى الأسماك والآن حتى قبل تقريبا أعتقد 4 years أو 5 سنوات السعودية بدأوا عن طريق وزارة الزراعة حملة للمحافظة على، طبعا اللي باقيين عليهم الحين يحافظون عليها. I would say it's almost 20% of what's left. The rest was already مثل عندكم هنا يصير دفن وتروح أراضي كلها وذا، فباقي مناطق بسيطة جدا جدا. لكن صراحة تشوفي هذا الطائر اللقلق والله تشوفي حاجات عجيبة في هالمنطقة.